Start time, right? Start time.
Good evening. A grand welcome to each and everyone. We are now live with the annual Chaithanya Academic Session 2021, Synoptic, an algorithmic approach to challenging clinical scenarios. First, I would like to invite Dr. Unikrishnan Nair, Medical Director of Chaithanya Hospital and Research Institute, to deliver the introductory speech. Over to you, sir.
Good evening, and it's very nice to see all of you, esteemed colleagues and seniors, and it's very nice. I'm looking at a very prestigious panel in front of me. I'm extremely pleased that we can start on time our yearly academics program of Chaithanya Academics, and without much delay, I'd be very happy, and we'll just start on time. Thank you very much. Thank you all for joining.
Thank you, sir. We will now move on to the first session of Synoptic, Cornea, External Diseases and Refractive Surgery. For this, I would like to invite Dr. Prashab Mohan, Consultant of Cornea and Refractive Services at Chaithanya Trivandrum, to moderate this session. Over to you, sir.
Hello everyone, and welcome to Synoptic. And as you know, this is a CME with a difference. We are looking at algorithmic approach to challenging clinical situations. So that we are starting off with the cornea session. We have a stellar panel today in cornea. Moment. With us is none other than Professor Dr. Namrata Sharma. She needs no introduction. She has a long list of publications and achievements, and she is a senior consultant, a senior professor at the RP Center, All India Institute of Medical Sciences, New Delhi. She's also the Honorary General Secretary of EBAI and AIOS. She has several achievements. One of the most notable ones would be she's one among the 100 most influential female figures in ophthalmology. That's a great thing. And next in line, we have Professor Dr. Rohit Chetty. Again, needs no introduction. He has many hats. He's the Vice Chairman of and the Consultant Cornea and Refractive Surgery at Narayana Nethralaya, Bangalore. And he has several, again, an unending list of publications and achievements. And the one notable achievement would be the Achievement Award by American Academy of Ophthalmologists. So thank you for coming, sir. We also have Dr. Anil Radhakrishnan. He is a senior consultant. He is heading the cornea unit at Amrita Institute of Medical Sciences, Kochi. And he's also a pioneer in lamellar corneal surgery in Kerala. Welcome, sir. We have with us a young dynamic corneal surgeon from Delhi, Dr. Rushad Shroff. He happens to be my colleague as well, and he has again several publications, and he's also a distinguished corneal surgeon from Shroff Eye Center, Delhi. Welcome, Rushad. And last but not least, we have our dynamic surgeon from Ernakulam, Dr. Sachin Matthew George. He's our own member. He's a part of Chaithanya Hospital and Research Institute, Pallaarivattam, and he also works as visiting consultant at many places. So without much further ado, I'll introduce my team, the team from Chaithanya. This is Dr. Anjana, Dr. Aiden, Dr. Priya, and Dr. Sanjana. They will be presenting the cases and discussing the algorithm. So the first item on our agenda is very much awaited keynote address by Professor Dr. Rohit Chetty, Tears to Brain, the role of diagnostics in dry eye. Sir, I invite you to illuminate us with your knowledge. Rohit Chetty, please share your screen.
Thank you, Unni. Thank you, Anjana. Thank you, Prasab, and all the team involved in this. Am I audible?
Yes, sir. Loud and clear. Please go ahead.
Sorry, I'm in a place which is not very good with connection. So that's the reason. So my talk today is tears to brain in dry eye, an algorithmic approach to diagnosis and management. And I do have financial interest with these companies, but that will not have a real implication on my presentation today. I'll divide my talk into the few things. I will look into the tears, the nerves, dry ocular motility, and the future. Oops. Okay. So this is the algorithm we follow in our practice. You look at the history, the questionnaire, the non-invasive test, the fluorescence training, and MGD classification, and all the other imaging technologies what we are planning to use. I'm not go too deep into this, but everything starts with the Shermers. Everything starts with the T-BUT times, and these are all the basic foundation of any dry examination. But a special emphasis on the questionnaire, the speed and other questionnaires. We have the speed, we have the ocular surface, and DQ5. They're all important things, very important part of our practice. So looking at the imaging starting from the tears, it starts with your meibomian glands. And these are the most important factors in your diagnosis, the grade of glands, how each of these glands are being categorized. Then it starts with the modern day non-invasive T-BUT times. There are technologies today, most of the commercial available technologies do give us an option of these beautiful glands, which help us to understand what is happening to your T-BUT, to your tear film. The lippy flow helps us to understand the different thickness and different profiling of your tear film. That is probably very important in our understanding of the lipid layer components. What is important in the whole tears to brain concept is the concept of tear optics. When you look at a tear optics, you look at the optical scatter index. The optical scatter index is the point spread function of your tear film and how the tear film changes with both in disease. This is your disease eye and this is a normal eye. This is just like your point spread function, what you see in your normal optical system. It also compares the T-BUT, the vision T-BUT, that is an optical T-BUT, into normal and abnormal, and anything in the green thing is perfectly normal. After the tears comes the corneal nerves. And the corneal nerves, one of the most important thing in corneal nerves understanding is decoding the neuropathic pain. And confocal microscopy has a huge impact on it. These are the confocal nerves. These are the healthy nerves. These are the unhealthy nerves. And these are your dendritic cells, and these are your microneuromas. All have a huge impact in understanding an algorithmic approach of a dry eye. For example, if you're looking at unhealthy corneal nerves, your OSDI score is high and the tear cytokines are more, and that creates a tremendous amount of discomfort. Compared to this here, which you have a microneuroma and you have decrease in your nerve growth factors. And you can have microneuromas and inflammation with different types of ocular surface problems and also the inflammatory markers. All this has a huge implication in how you manage them. Basically, they can be managed with the conventional ones, or sometimes you may need some autologous serum in them, or a mix of both is what is necessary in many of these patients. Tear biomarkers plays a very important role in our understanding. It may look very researchy at this point of time, but over time, this probably would be the foundation of it. For example, when you're looking at the modulators of nociception in the tear film, I'm very proud to see Anjana here, and she was one of those people involved in a lot of this nociception work of tear film. Basically, what we try to do is we looked at the inflammatory markers which could irritate those nerves, and these nerves could have a huge impact in the outcome of the quality of life and quality of vision also. And these biomarkers have been linked to vitamin D and B12. And these are some of our publications which clearly states the importance of these nerves. When I move from the nerves, one of the most important thing we are working on is a nexus of ocular motility, accommodation, and dry eye. It's a very important component which very, very rarely we actually put an effort into. Why is it important? We call the nomad axis is because when there is a tear film breakup, there is a change in the way the accommodation works. Is the corneal nociception linked to autonomic input? Are there any neuronal connection between central ocular pain and autonomic accommodation? This again is a work by my present fellow, who I think was a student of Dr. Namrata ma'am, and again did a lot of good work. Dr. Bhavya, a lot of good work in how this whole nexus works. When you look at this nexus, there is a not direct connection there, but a lot of indirect connection between your neurosensory, feeling of discomfort to how your pupil responds, how your accommodation happens. And these things actually have a tremendous impact into astigmatic and glare and photophobia. And many times patients don't understand, but they all complain of dry eye, even though they have all these problems. So this is very important that we take care of this. This is a very important component in tears to brain concept. And when these patients also do have a lot of mood changes and personality changes. And so dry eye is becoming like a psychological problem. It's like dry eye is not just an ocular surface disease. It also has a huge component of a psychology or psychiatry involved in it. That's what we want to bring it out in this presentation. And this is a beautiful paper by very old paper. It looks at the mood changes and the type of moods you have and how your accommodation changes. It's very important because mood changes, dry eye, accommodation issues, nociception changes, all linked to dry eye, all linked to the symptom of dry eye. That means you may not have any signs of it, but you may have a symptoms filled with it. So we have to be very clear about these factors when we practice. And this is one of those pathways, very old pathways about how the ciliary body works in both dry eye and also in cases of in cases of stress, which all we see in our daily practice. Let's look at some cases. A 50-year-old lady complains of burning sensation, headache, been treated with dry eye multiple places, everything else perfectly normal. T-bud time was less, but look at her OSDI, very high. Meibomian glands was normal. Other tests were normal. And what you see is divergence insufficiency in these patients. It's been treated for dry eye, but we never looked at it from a divergence insufficiency, even though there was a small component of dry eye in evaporative dry eye. We treated the dry eye, but gave her a lot of home-based exercises. And this, when you give the home-based exercises, within 1 week, the patient completely got better. The dry eye still remained the same, her T-bud remained the same, but OSDI drops from 56 to 1 or 2, virtually here nil. This emphasizes the importance of binocular vision abnormalities, which is the important component of tears to brain concept out here. And this is again one more patient with dryness, ANA negative, just can't bear it. Again, treated with dry eye in multiple places. And you can see that both this components are abnormal, which says that there's an accommodative insufficiency, a secondary convergence insufficiency, and related to evaporative dry eye. Again, started giving exercises, and this is how it changed and completely changed. You don't see a change in the dry eye components, but you change it. That's what you need. You're not interested in the metrics, but you're interested in how the patient does. And we gave them flippers and block strings and these exercises for them to get better. Beautiful example of your accommodative spasms and absolutely nil at the end of, you can see the cornea remains the same, but see the change in this. Beautiful. It's a perfect example of, this is one of the dry eye patients we treated, which has been labeled as dry eye and always pumped into many things. So you have to look out of the box when you treat. There are so many other components other than just your T-bud, Shermas, and ocular surface issues. This is what I just mentioned. And this is an image of how we check for an accommodation. This is the healthy accommodation. This is a topography. This is a dynamic barometer. How healthy accommodation. This you become suddenly myopic. This is what that means. The patient is accommodating, and when there is a poor accommodation, you see there's a lot of lag out there. Something wrong with the slide. Yes. So basically, this is how we do an algorithmic way. We'll do all the routine ones. I do put a lot of emphasis on my dry eye test. I use a lot of scoring. We try to differentiate between evaporative and severe aqueous deficiency. Aqueous deficiency needs, I'm sure there's somebody who's going to talk about it, rheumatological test, to treat them differently with the cyclosporin, steroids. And when we try to look at evaporative dry eye, look for ocular fatigue, eye strain, astenopias, and other stuff, and look for any orthoptical changes. And if there is an orthoptic changes, you can even look at an eye trace, or if you have an accommodative changes, put a lot of emphasis on the psychology, because that's one also really helps. So what's the future? This is what I mentioned in my previous one. This is the next generation. When we look at building a kit, this is what we do it in the clinic now. For a long time, we used to show that this used to be in the lab. Now, this is one of my fellows doing it, and you can do it on a chip. And the chip is now directly in our clinic, and it takes 30 minutes. And you can probably get you a lot of, this is a report which gets you to the patient, which tells you the virtually lots of inflammatory molecules. And some of those molecules were even VEGF-As, ICAM, these are all for the retina also. And over time, I think we'll have a lot of these things in our practice. This is not something which we do it in the lab. Now it's there in the clinic. We're also working on ROP, again, because the topic is about the brain. And, a lot of times, prematurity, VEGF changes, anti-VEGF, and all that, multiple things are there. Even the VEGF can be detected, even a child's. Dopamine is one more area in myopia where you can work on dopamine and looking at the myopia growth factors. I thank all the bright minds, both clinicians and scientists. These are all scientists working from different areas. And it's a fantastic topic, and it's been nice speaking to you all in this format. Thank you.
Thank you, sir, for that wonderful talk. You have illuminated us all with your knowledge about the role of diagnostics, and you have taught us about out-of-the-box thinking. Now, I think we'll move on. We have a tight schedule, so we will move on to the case presentations. First up, we have Dr. Priya Nair. She's a senior consultant and refractive surgeon at Chaithanya Eye Hospital and Research Institute, Cornea. And she will be presenting on when and how to roll the dice in refractive surgery. Over to you, Dr. Priya. Please share your screen. Yeah. And you can unmute yourself.
Shall I start? Good evening, everyone. I'm presenting a confusing pentacam. A 27-year-old female, she presented for refractive surgery. She gives a history of being recently married. Her refraction was stable at -5 and -5.5. She gave a history of contact lens use, which was discontinued 2 months back. There was no history of eye rubbing. There was no significant cylinder on autoref. She had lattice degeneration, which was barraged. The Sherman's was normal and her ocular surface also appeared normal. When we check the pentacam, this is the right eye. It showed a suspicious asymmetric bow tie pattern. The anterior elevation of the right eye was borderline, around +8 to +9. The posterior elevation was around +12. The steep K was 44.1 and Paki 531. When we checked the superior inferior, the difference in the K, there was an inferior steepening of 1.1 D in the right eye. Berlin ambrosia, however, did not show much of a problem. There was just a yellow flag for the DF. The Paki progression index, CTSP, PTI were all normal. The refractive map, however, showed a flagged index of high decentration and it labeled the patient as unsuitable for classic. The other eye also showed a similar picture. Here again, there was a suspicious asymmetric bow tie pattern. The anterior elevation and posterior elevation were normal, around 6 and 9. The steep K was 44.2, Pachy was 529. And here also there was an inferior steepening of 1.4D. Here again, the Bellin-Ambrosio was absolutely silent. The Pachy progression index, CTSP, PTI were all normal. The refractive map, however, showed a flagged IHD and again labeled the patient as unsuitable. To quickly summarize, basically this patient had an asymmetric bow tie, a borderline anterior elevation. The steep K, Pachy were all normal, but there was a significant inferior steepening of 1.1D in the right eye and 1.4D in the left eye. And the refractive map showed a flagged IHD and labeled the patient as unsuitable. On calculation, the residual stromal bed, if we did the procedure, would have been 357 microns in the right eye, 352 in the left eye. And the percentage of tissue alteration was very much within normal limits, around 33%. Now I leave the case open to discussion.
Thank you, Dr. Priya. Can you stop sharing the screen? So it is a very interesting case. We are opening this up for panel discussion. First of all, I'd like to call Dr. Namrata Sharma. I'd ask you a question regarding how will you proceed in these cases? Would you go ahead with the normal refractive surgery, that's LASIK or PRK or SMILE, or would you do something else, or would you wait? Dr. Namrata? Dr. Namrata, can you hear me? Ma'am? I think she has lost the connection. Actually, any of the panelists can, Dr. Rohit?
I feel that there is definitely an early posterior change and small amount of skiving. I think I missed her. What was the refractive error you were planning to correct in this?
Right eye was -5 and left eye -5.5.
I would consider, if you want to do something, you can consider an PRK, or ICL would also be a good choice if it's so. LASIK, irrespective of how your PTA and others are saying, definitely there is small amount. And if you have an epithelial mapping, it would be nice to look at an epithelial mapping if there is an epithelial hyperplasia of that area, epithelial thickness, but that definitely doesn't look healthy on the posterior. So PRK would be the first choice.
Thank you, sir. What made you decide on PRK? Is it the index IHD or is it the posterior?
Oh, I really don't put too much efforts on a lot of indices. I look at the topography as a whole. Okay. If you look at it, there is an inferior stapling, the same area, there's some posterior changes. I saw the Pachy there was a little thinner on that zone. And if you can put that map again, if you have a minute, if you can put that map again, go to the first map, please.
Dr. Priya, can you share screen here?
The third slide. Yeah, what is interesting here is also look at the X and Y coordinates. You can see that the X and Y is around 0.70 and 0.14. That is decent. But it's little deviated here. Show me the other map, please. The left eye, please. In the left eye, again, it's around 0.83. So you see a little bit of change out there, but it's like I said, there is some amount of skiving in your left eye. It's not, and the skiving is extremely important point, especially in these conditions, which make me to skive towards PRK or an ICL, and which is not so much in the left, but definitely it's a 10 to 15 degrees skiving of axis. And the area of steepening 44.9 actually matches with your posterior elevation pretty well. So take home point for me in this case is don't trust blindly on indices. Your bad D is normal here. Your PTA is normal here. Never trust on indices. Go case by case, point by point. Indices just is an additional tool you have, not the only one.
So, would you consider any other additional investigations, especially? I know you are using a lot of corneal biomechanics.
Yeah, biomechanics, yes, but I would do epithelial mapping, and biomechanics would be two areas of interest. Probably this would look like a poorer biomechanics one. That's why I'm looking at PRK, nothing else.
So what will you do in how would you go about measuring corneal biomechanics?
There are tools I use is called Corvis. Corvis looks at now Corvis can be connected to your topography, so it gives you indices called CBI, which is only the biomechanics. TBI is which gives you combination of biomechanics and biomechanics and topography, and this will tell you additional tools of combination of AI driven one, which is the culprit out here, whether the topography or the biomechanics and all that. So it really helps to make a judgment.
Thank you, sir. At last, I'd like to ask Dr. Rucha. There are many hospitals, many places which sprinkle a little bit of riboflavin on top and do a cross-linking. I call it extra procedure. What is your opinion about extra procedures in such doubtful cases? Are they necessary or are they effective? What is the evidence for that?
So actually, there are a fair number of publications. Thanks for the question, Prashop. There are a fair number of publications talking about the advantages of extra, but practically, again, when I was at NN with Professor Shetty, we had done some studies on this as well, which showed effectively that the biomechanics was pretty similar in a patient with undergoing extra versus a patient undergoing a conventional LASIK or PRK. And when we compared the biomechanics between the different procedures, the PRK was much superior to the other two, including SMILE or LASIK. Extra, however, did not add any further benefit. And there's a paper by Professor Randleman about this recently. They've looked at brilliant microscopy to actually see whether there's an added advantage of doing an extra procedure, and they haven't shown a significant difference. So I'm not a big fan of it. I don't personally do it if there is a suspicious topography. Like was shown in this case, my first reaction would be to observe this over a period of time. In fact, there was a very nice case again when we were at NN that we had seen, just like an inferior steepening which progressed over a period of time, just observing it, and it went into a frank keratoconus without any refractive procedure. So that would be the first kind of way. Refractive is always not an emergency procedure. It's better to be overcautious in these cases and not to go with a single indice. But as far as extra goes, I would not really be keen on extra procedures as such.
Very valid points. I would like to ask Dr. Anil. Nowadays, there's a tendency, especially in the states of Telangana, that's what I've seen, especially LVP, I know, that surgeons are shifting more towards PRK. They've abandoned LASIK altogether, even for higher powers, like 8-9 doctors, they are doing PRK. They say that the incidence of haze is less. What's your take on that? I mean, would it be safer? Would it be more effective? What about haze?
Okay, before I speak a word, Prashop, I would like to compliment you and Unni for this selection of topics and inviting me for this particular important meet. I think I consider myself still a part of Chaithanya family because I spent close to 7 years there. Coming to the question, I think regarding surface ablation, I think Dr. Praveen was my colleague and I have interacted with him multiple times regarding this. I think almost 65% of the work that they do is almost surface ablation now. You know, it is something really out of the way. But in my hands, I would try to limit that number for sure, because I feel that the comfort of the patient and for us, it's much better to do a laser ablative procedure like a LASIK. PRK is definitely the amount of biomechanical damage it causes to the cornea is very less compared to a flap-based procedure like excimer or a smile. But definitely, I think I don't have too much of an experience regarding that. I have done some 12 diopters and all that. I think approximately I would say less than 10% of my work would be PRK.
Okay, thank you, sir.
Honestly, tapering steroids over a long period, avoiding sunlight for a long 3 months, 6 months. I think those are all quite cumbersome things, and it's not 100% predictable. It's sometimes small errors can creep up.
In my personal experience, we've done a lot of PRK in 5 hours, do femto and PRK both. But we are pretty comfortable now doing what we do is a transepithelial PRK. But we are pretty comfortable in doing regularly 9 diopters and without any haze. Occasionally, one haze comes in. That's irrespective of the person. Sometimes we get haze in a 5 diopter patient. Sometimes we don't get haze in a 10 diopter patient. So maybe the number of diopters that we treat, maybe the depth is not really related to the haze. I do use mitomycin C. I don't know if that makes a difference. But in my personal experience, it's pretty safe. Any other panelists have any differing opinion regarding this?
No, I think I agree with you, Prashobh. Even for haze in PRK, I've seen it very randomly. It sometimes even in a very low power, you can land up with haze, but it's not a given. I mean, I've gone up to about 5.5, 6 diopters with PRK and not had haze in some patients. So I think there is something else that drives the haze rather than just the diopters of ablation.
We did a comparative study recently, and it presented in the state conference, and it showed that there's no difference between in effectiveness and both in effectiveness and in haze. So, is Dr. Namrata back? Ma'am, are you here? I don't think we have her. So I think we'll move on to the next case. Next case is by Dr. Ayden. She's a senior consultant at Chaithanya Hospital and Research Institute, Bandra. And she'll be talking about the case of peripheral ulcerative keratitis fighting a two front. Dr. Ayden, please go ahead.
Good evening all, coming to the second case of the session. This is a 60-year-old lady who came with redness, painful swelling in the sac region of the left eye, along with lid edema and yellowish discharge and diminution of vision of the left eye of 2 weeks. When she presented to us, she was already on tabbed doxycycline and antibiotic eye drops and lubricant eye drops from elsewhere. She also gave a history of chronic bacteriocystitis, for which she had recurrent acute exacerbations for the past 30 years. She was advised surgery for the same, but she had deferred it. And however, she was symptom-free in this regard for the past 2 years. She was a hypertensive. She gave history of polyarthralgia involving the hands and knee joints for the past 2 years, for which she was not on regular follow-up or treatment. Last 2 months back, she was diagnosed with osteoarthritis of both knees, for which she was advised surgical repair, but she was yet to do it. And this was her right eye. The uncorrected vision was 6/6. It was clinically unremarkable except for mild meibomian gland dysfunction and a poor tear meniscus. Right eye had a vision of counting fingers at 1 meter, which was not improving with pinhole, and it showed an inflamed eye with partially ruptured lacrimal sac abscess. And the cornea showed a juxtalumbral area of arc-shaped area, proxentic area of thinning of around 80 to 90%, extending from the 4 o'clock to 11 o'clock position. And 4 o'clock edge of the lesion had an anterior stromal infiltrate involving the anterior 2/3 of the cornea. These were her blood investigations, which showed an elevated ESR and C-reactive protein. And a blood work, systemic workup to rule out any connective tissue diseases turned out to be negative. The lacrimal sac abscess was drained and the contents were sent for cultural sensitivity, which was reported negative for bacterial or fungal growth. And finally, the area of corneal thinning was sealed with cyanoacrylate glue and BCL was inserted. And she was started on topical and oral steroids and antibiotics. She was planned for a dactyl cystodynostomy, and a rheumatologist consultation was sought to find a possibility of steroid modified rheumatoid arthritis. And she was asked to review after the tapering of the oral steroids for a repeat investigations. The patient was symptomatically, however, better and clinically improved with the treatment. And I leave the case now open for discussion.
Thank you, Dr. Kaptaidin. It's a tough case to manage. I hope you have Dr. Namrata back.
Yeah, I'm there. I got disconnected. I'm sorry.
Welcome back, ma'am.
With the net.
I hope you were able to listen to the case.
I was able to see the pictures and also the investigations and the fact that it is a PUK, which was, I think, glued, if I'm not mistaken. And,
yes, Dr. Aiden, can you just show a summary? Show it once again. The patient also had a history of acute dacrocystitis, acute on chronic dacrocystitis. And the concentric area of thinning and infiltrate was in exactly the infronasal area. What we are discussing here is mainly, do you think it is an infectious case or is it clearly an immune case? How will you go about it? After gluing.
So I heard you did culture sensitivity also for the I think lacrimal sac abscess was drained and culture sensitivity was done.
Yes.
And okay, there was no growth there. So I think this is a very unusual case where you have a lacrimal sac abscess and PUK both concomitantly together, and it is difficult to say whether the infection, what traveled from the sac to the area of the PUK. I think, to my mind, I feel that probably these two are not very much related events, although because the PUK doesn't, the lesion doesn't look as though there were any infiltrates on the lesion. It looks more like a sterile melt, and I don't know if any scrapes. I'm sure they wouldn't have been, because there are no infiltrates present on the peripheral ulcerative keratitis area, would have been, sent for culture.
There's just one or two infiltrates. Not doesn't look like.
Yeah, they look like two separate things, and glue was done. Having said this, the largest series that we have, at least from North India, where we looked at about 67 plus cases of peripheral ulcerative keratitis, the commonest cause for all of them was infection. And that was bacterial, and then there were some cases of herpes also which were present. And of course, Morin's was also there. So this doesn't look, to me, it doesn't look infective. And I know it's a challenging situation to drain an abscess in the presence of a lesion like, PUK over there, which is almost melting from one side. But yes, the way to go would be gluing the case, like the way Dr. Iodine did, very nicely presented. And if in case even that doesn't stay, then you'll have to do a crescentic patch graft for such a case.
Thank you, ma'am. I hope we still have Dr. Rohit with us, Dr. Rohit Shetty. Is he online? That's okay. Then anybody can take the question.
Yeah. Can I comment?
Yes, ma'am. Yes, sir. Please.
I think if you look at the blood work, as Namrata ma'am was telling, the morphology doesn't look like. Am I audible?
Yes, sir. Yes, sir. Yeah.
I think certainly my screen went blank. Anyway, I'm speaking. See, the morphology of the lesion obviously looks like a PUK. And if you look at the blood parameters, 125 ESR and CRP also very high. It points more towards a serious connective tissue disorder than an infection per se. It's possible that the initial workup by the rheumatologist may be underwarding. Later in, I think rheumatologist probably has to look into maybe a second visit to the rheumatologist may be worthwhile. Regarding the management, I think you have done what is exactly necessary. You have done the scrapings. See, based on the scrapings, I don't know whether we can say, because in a good ophthalmic center, the culture positivity is near around 65%. This KOH or your smear positivity is 85 to 90%. But in a non-ophthalmic place, like if the microbiologist is not an ocular microbiologist, the rates really come down. It's nearer to 10% or so. And even the culture positivity is very low. So we cannot rely too much on culture positivity. But having said that, it looks more like a autoimmune destructive phenomenon of the peripheral cornea. On top of that, there is a lacrimal abscess also. I think this vaginous especially is known to cause lacrimal abscess, and also it causes erosion of the palate and nasal mucosa. So, but I think ANA was negative. Are you CNCA and PNCA was also negative for this?
Yes,
patient?
all the markers were negative.
All the markers were negative.
But she has joint pain, symptoms of multiple joint pain. So actually, the rheumatologist's opinion was that it may be a steroid modified, because we started her on steroids, systemic steroids. So because the cornea, just progressively melting. So his opinion was it may be a steroid modified RA. And that is what his opinion was, rheumatoid arthritis. So that's a little confusing situation. Will you consider any other procedures other than blue BCL, Dr. Anand?
I think at this point of time, blue BCL appears. We want
Blue
to
BCL.
yeah, that is the best way to go about it, I think.
The conjunctival resection, and you reserve it for other cases?
Okay, you mean conjunctival resection?
Yes.
No, I didn't get your point there, Prashu.
Conjunctival resection. Would you do the conjunctival resection along with the blue BCL?
Yeah. Along with the blue BCL, I would have definitely done a conjunctival resection also, because
in this case it's just blue BCL. That was
okay. I would have preferred to do conjunctival resection also, because we can take care of some local auto-inflammatory process and complement activation and corneal destruction in the periphery.
Yeah, Dr. Sachin, would you hesitate in starting steroids for the special, either topical or systemic, because there's a bomb sitting next door? So, would you just start the topical steroids right away, or would you wait? Will you with your approach? In fact, this patient, when she presented to us, she was just getting topical antibiotics and oxide, no steroids at all, either topical or systemic.
Right. Thanks, Prashant, for inviting me. I mean, this is a very rare situation, as everyone said. I mean, you can't have both the problems at the same time. I mean, rarely we see a PUK and a lac abscess. I mean, just now Anil said about vaginous, but it's not very common also. I would say, we have to treat it as two separate entities, but together. I mean, we have to. You should definitely start. I would have started the Predford. I mean, topical steroids along with the treatment of dacryocystitis. I mean, with an antibiotic, oral antibiotics, and if surgery is needed, we can do combine also. I mean, the glue and BCL and abscess drainage. I mean, in a stepwise manner, but do it concurrently. I would have done it together. Yeah, right.
Thank you, sir. Dr. Rushad, any comments?
No, I think agree with the management completely. I don't think I would have done anything differently, except probably the conjunctival resection would have been done along with the PABCL. It definitely looks immune rather than anything else. It doesn't look infective. Probably would start the systemic steroid just a little before the topical steroid in this case. Just give maybe a day or two and then.
Thank you all for the discussion. I think we'll move on to the next case. Next case. Dr. Sanjana?
Yes. Can you see the screen, sir?
Yeah, it's just coming on. Dr. Sanjana will be presenting a case on dry eye, the snake and ladder game. He's a cornea refractive consultant at Chaithanya Hospital and Research Institute, Tiruvallur. Yeah, go ahead.
Good evening, one and all. Chaithanya Hospital for giving me this opportunity to present the case.
Go ahead, Sanjana.
Yes. Is the screen visible?
Yes, screen is visible. You can make it full screen.
Okay. Yes. Here is a 40-year-old male patient who presented to us with complaints of irritation, photophobia, eye pain, and transient blurring of vision since 1 year. His past history revealed he was suffering from acute myeloid leukemia, for which he was undergoing an allogeneic bone marrow transplant, following which he suffered from an acute GVHD, followed by a chronic graft versus host disease, and currently he is in treatment with tablet Vicelon and cyclosporin. Ocular evaluation showed his uncorrected visual acuity was 6/6 in both the eyes, grade 3 meibomian gland dysfunction, reduced tear film height, and conjunctival congestion in both eyes, with punctate epithelial erosions more in the left compared to the right eye. A dry eye workup was done with the help of a comprehensive ocular analyzer, which revealed the following values. More so in the left eye, the values were much more deranged compared to the right eye, with reduced lipid layer as well as tear meniscal height. 67% of meibomian gland loss was seen in the left compared to 49% in the right eye, with overall result of OSDI of 46 in both the eyes. Schirmer's was 0, T-BUT was 3 seconds, and ocular surface staining was grade 3 in both the eyes. Putting together all the findings of history and diagnosis, we came to the conclusion that there was an evaporative component of dry eye also, along with his aqueous dry eye. So based on this, patient was given copious lubricant, topical immunomodulants, along with the currently intake of oral immunomodulants. In addition to this, what different we did was we gave him an intense pulse light therapy of 3 sessions. This actually helped the patient. So following this, after 3 months, we repeated the ocular surface analysis, and these were the values which we noted. There was a significant difference in the left eye comparatively, with 82% increase in his lipid layer and a tear meniscal height of 0.22 compared to the previous one. And in the right eye also, we saw a significant improvement. His OSDI was 33 compared to 46, which was prior to the procedure. So here I close my case. Thank you.
Yeah, the case is now open for discussion. First, I'd like to go to Dr. Sharma. Ma'am, in this case, we have not modified any systemic treatment. We just continued. Ma'am, are you here?
Yeah, I'm there. I'm there. Sir.
Yeah. So we have modified. We have not modified the systemic treatment for GVHD. We've just stepped up the topical treatment. We have done the IRPA. What do you think about this line of management? Should we just give the topical therapy, or should we consider stepping up in the systemic treatment?
So what actually happens with GVHD is that slightly different from what otherwise you would have dry eye due to, and the first would be the first line of treatment, or the first step is that you step up the topical medications, and if it doesn't improve, then you add on the systemic therapy to it. So I think what was done as a first line of treatment was quite correct. That you did start topical steroids and you did add cyclosporin to it, and all the parameters in fact showed improvement as was expected, coupled with the IPL therapy also, and that also helped to improve the parameters. So I think as a first line of treatment, the only problem is that if this topical therapy had not helped, then what would you have done? So that was the thing. At that point in time, you probably would have to step up the systemic therapy. But since it is showing improvement now, I think topical therapy stepping is the first step in this, which has been correctly done.
Thank you, ma'am. Do you come across GVHD cases quite regularly, or is it a very rare thing?
So GVHD is, I'm not saying very regular, but yes, we do see a lot of GVHD because ours is a super specialty hospital, and we have a whole IRCH, Indian Rotary Cancer Hospital. So they do refer GVHD, cases to us, and we do get such cases. So I'm not saying they're very regular, but it's not a rarity at all. I mean, we do get a couple of them, say, in a month.
Thank you, ma'am. I think we have lost Dr. Rohit. Is Dr. Rohit here? Maybe a bad connection. So I'll go to Dr. Roshad. You have a few new gadgets in your practice, new advances. What do you think about this? The newer drugs? including the IR. Sorry for that.
Lost your voice in the middle.
Yeah. What do you think about the newer treatments for dry eye? The intense regulated pulse light, and the newer medications, hypofosol, ribamapide, etc. Do you think there's evidence for them, or do you think it's worth pursuing? Do you think practices should invest in getting these drugs?
So I think, Prashub, to answer your question shortly, these are helpful. We have done some studies on them ourselves also. I've done a study on cataract, pre-cataract treatment with LipiFlow versus treating them with just an eye mask, the usual mask that we get, which is either the Evolve or the Brooder or one of those, and versus non-treatment. We had actually randomized these eyes to these three groups. And we did find significant improvement in tear film metrics and in OSDI scoring in the patients who underwent the LipiFlow treatment arm. But is it cost effective to get it? That is a separate question. If it was a procedure that didn't have a consumable, then probably it would definitely be worth it. Not in every case. You do have to look at your parameters before you do it. So if you have a definitive MGD, and which is not a complete dropout kind of MGD where it's more obstruction, then these things help. I think the IPL helps by working on the telangiectatic vessels. I don't have personal experience with the IPL. I have it with the LipiFlow, which we have done the study on, which we are in the process of publishing. And I had pretty good results in this particular study regarding cataract patients. Pre-cataract surgery and looking at their parameters post-cataract surgery. Regarding the newer drugs, I think things like even autophagy are affected by trehalose and these kind of things as well. So there is some evidence. There are publications talking about that as well, the role of trehalose in regulating autophagy in dry eye. What we have to understand in dry eye is it's become such a broad term that, there are a lot of patients who don't have necessarily signs suggestive of dry eye. They have symptoms, that category of so-called pain without stain. Now, the treatment for them is kind of different. They don't typically respond to things like MGD treatment. You would have to go into a little bit more detail, like I think Dr. Rohit had shown, vitamin D, B12 levels. Look at, if you have access to a confocal microscopy, then things like dendritic cells, how the nerve parameters are changing in terms of fiber width and density. All these things are more research-based because it's not something that we can actually see. And also there are these two categories of pain, neuropathic and nociceptive pain. Now in neuropathic, basically what it means is that the receptors are responding to non-painful stimuli, which is a normal stimulus will, because of an upregulation of the receptor, it responds to that with a painful response. In these kind of patients, then I look at central and peripheral mechanisms by putting a drop of Paracaine. If it's more of a peripheral pain, that will get stopped by that. You can even put them on a contact lens to see that. And if it's a central mechanism, then something like pregabalin or gabapentin helps with this kind of pain. So it's a pretty large algorithm to treat these patients.
Do you give pregabalin and gabapentin yourself, or you do refer to
I do. I generally have a word with a physician once before giving it, but I do prescribe something like pregabalin 75 mg once a day for a little while at least.
Okay, that's interesting.
Yeah, Prashub, can I add a point?
Yes, please.
Yeah, I think in this patient, if you look at the that you see, I think there was a lot of punctate erosions on the cornea, and Shurmas was zero.
Can you show the slide with the staining?
Basically, Shurmas was zero. No, that tells you that the amount of aqueous component of dry eye is very severe. So that has to do with the graft versus host disease. Obviously there is an evaporative component, but I think 35% of movement glands were present, which tells you which can actually have like you can protect the oily layer. So I think it's more of an aqueous sort of dry eye, and I think it's important for you to, as an ophthalmologist, I think our part is over when you treat the dry eye, but it's very important to alert the hematologist, because if the graft rejection is not taken care of, it can manifest in some other part of the body. It can present with myositis or something else. So I think we have to alert the hematologist and.
So your sound has gone up.
Yeah, am I audible now?
It's very feeble. If you can speak louder.
Okay.
Now it's clear. Now it's clear.
Yeah. So if you can, you should talk to the hematologist and probably step up the systemic steroid therapy if he or she is okay to do with that, because they have to look at the blood parameters and confirm the diagnosis of GVHD and then take a call to that. Obviously, for the ophthalmologist, I think you have done what is necessary.
Very important point that we have to liaise with the hematologist as well.
Prashant, can I interrupt for a second?
Yeah, please.
Yeah, so any experience in the panel with that too?
Dr. Sanjana, can you mute yourself?
Yeah, with Crow's lenses and moisture chamber glasses, because for very, very severe aqueous deficiency, I have given a few patients Crow's lenses. They're sometimes quite happy, but it is cumbersome to use. Not everyone is happy with those. So any like idea regarding those? And a lot of patients are looking for moisture chamber glasses, but I don't think they're easily available in India. So that was another thing I just wanted to ask. If
lenses mostly out of reach for the large majority of our patients because of the cost. They would rather suffer the dry eye than the cost. So that is there. Moist chamber glasses, I don't routinely prescribe them, but I have asked some patients to use the regular protective glasses that have covering. And sometimes I ask them to keep a moist blood with a cotton. That has helped some patients, and not just anecdotal. Probably moist chamber glasses may. Good perspective. Now I'd like to go to Dr. Anil again. Will you consider any surgical methods, surgical management in this case? You did the first submandibular gland transplant.
I don't think, because see, if it has improved so much with your topical treatment, why should you think of anything else? I think maybe I'll think of flux also. I think I have a few patients in whom I use flux, and they have improved at least marginally. Some of them have like shown 30-35% improvement.
So Dr. Sachin, what kind of lubricants would you use? Is there one lubricant that is better than the other, or in specific case, is there a caveat that in certain cases you should use this lubricant? What is your opinion?
I mean, the thing is, like, I mean, here we are dealing with something like a very severe condition, so we cannot go for the basic stuff. But she has given a sodium hyaluronate 0.1. I would have maybe combined it with the CMC, sodium hyaluronate combination, which can give a little more better results, and all the gels. And so there is, again, I mean, I think we are going to discuss the algorithm regarding, so a very mild condition, we start off with either a CMC or an HPMC, and then a combination of CMC with HA, and it goes like that. But that comes with sort of your own experience, and then goes like that. But here in this case, sodium hyaluronate was, I think, the right choice with the gels, and yeah, right. This autologous serum would have been a good choice. But, the thing is, like, getting it is or formulating it is a little difficult because of the contamination risk and things like that. But otherwise, GVHD, it has been proven very effective. Yeah, right.
I think for that matter, even cord serum is a good choice, umbilical cord serum. But like you said, Dr. Sachin, availability is an issue at all.
Contamination also.
And contamination both. Yeah. And then the patient compliance, so that it is kept refrigerated at all times, and so those are the issues with it. But they do have more. They do help more than rather than just lubricants.
It was easier available when you are in it was easier available when you are in an institute. Like when I was in Arvind, it was like a common thing. Getting an autologous serum was like part of your treatment. But when you are in private, it's a little difficult to, or most of the setups.
There's a recent paper in Cornea, very recent, which looks at fingerprint blood. So each time the patient pricks his or her finger and puts the drop of blood, apparently it's
oh.
That's in the latest Cornea, I think. Latest Cornea. So that's a thing to consider. So I think we have run out of time for the discussion, and thank all the panelists for this wonderful discussion. Please don't go away. We still have a power-packed keynote address from Dr. Namrata Sharma coming up. She'll be delivering a masterclass on microbial keratitis. Over to you, ma'am.
Thank you, Prashab. And at the outset, I would like to thank Chaithanya Eye Hospital for making me a part of this very important scientific deliberation, and Dr. Sahasramam and Dr. Unni for inviting me. I wish we could have, come physically, but then I think that's not possible, and I don't know for how long it will remain not possible. I hope it ends very soon. I would be talking to you about microbial keratitis, the management algorithm, and there are no financial interests or disclosures to make. I would be talking to you about bacterial and fungal keratitis, although there are others like herpes and parasitic keratitis and viral keratitis, which also may need attention. I think it is important, and everybody knows that the symptoms are redness, sensitive to light, which is increased, visual acuity, which is decreased, pain, discharge. And whenever conjunctivitis is present, then you should suspect these three organisms: gonococci, pneumococci, and Haemophilus. And of course, there can be risk factors. Like in this case, the risk factor is an epithelial defect following penetrating keratoplasty. So epithelial defect after anything, eyelid disease, contact lens use, previous ocular surgery, ocular surface disease, compromised corneas, and inadvertent use of topical antibiotics, steroids, and traditional eye medicine. Then, of course, systemic factors also play a very important role, like diabetes, rheumatoid arthritis, chronic alcoholism, severe malnutrition, extremes of age, and AIDS, where actually it really doesn't matter about the organism, but the microbial keratitis tends to be a little more severe if you don't have HIV positivity case. Then on slit lamp examination, it is important to examine everything: the area and density of the infiltration, which is different from the area and the size of the epithelial defect. Then the depth of the ulceration is important, and you need to know the degree of stromal edema. Here it is clear, and here it is edematous. Then the scleral involvement, if any, and anterior chamber reaction as shown. So like I said, the size of the epithelial defect is different from the size of the stromal edema, and you can see here the size of the epithelial defect. And each time the patient comes, you have to document both. And when the patient changes position, then it is also mobile, generally, but not always. The fungal keratitis tends to have a fixed hypopyon. I think grading is very important for all kinds of ulcers because that determines the treatment. So it could be mild, moderate, severe, depending upon the size of the ulcer, depth of the ulcer, and it is easy to remember 2 to 5, more than 5, less than 20, 20 to 50, more than 50. And likewise, the infiltrate extent, which is superficial, mid stroma, and deeper than that, and scleral involvement, as is shown here after inadvertent or injudicious use of the topical steroids. So sometimes you can just pick up the organisms by looking at the ulcer, but of course, it's not always very easy. Punched out lesion with the surrounding cornea, which is quite clear. Non-edematous is a staph or ulcer, but when it is rapidly progressive, serpiginous ulcer with descemet membrane folds, hypopyon, and deep stromal abscess, you have pneumococcal ulcers. Pseudomonas is classically having a ground glass stromal appearance with greenish yellow discharge, infiltration in 24 hours, ring ulcer in 48 to 96 hours, desmetocele perforation in 2 to 5 days. Then you have mycobacteria species, which generally tends to occur after trauma. Indolent ulcers, classical cracked windshield-like appearance like this, with the surrounding cornea, which is quite clear and hardly any AC reaction. Subsequently, you can have Moraxella ulcers, classically inferior, oval, seen in diabetics, alcoholics, and they tend to have hardly any AC reaction. Cornea is appearing to be clear also. Nocardia, on the other hand, has a flower-like pattern and cracked windshield appearance, such as seen here with satellite lesions. So almost 3/4 of the times, the clinical examiners can predict presence or absence of, distinguish between bacterial, fungal, amoebic keratitis. And of course, a lot of factors will attenuate the clinical diagnosis and hamper the microbial recovery as well. So corneal scrapes are, or microbiology is the mainstay for diagnosis, and classically we like to use a 15-degree blade and take the scrape from the leading edge and the center of the ulcer. If you have to do just one stain, it is KOH, which is important to rule out fungal hyphae. If you're allowed 2 stains, then it's grams and KOH, because grams will pick up bacteria, yeast phase of gramophic fungi and fungal hyphae. And if it is recalcitrant ulcer, then you can even do acid pass for man, and man is mycobacteria, actinomyces, and nocardia. Classically, we do a culture on blood agar, chocolate agar, and supports dextrose agar for various organisms, as is shown here. And again, in recalcitrant cases, you can culture on LJ media for mycobacteria and non-nutrient agar with E. coli for acanthamoeba. Everything that is associated with the microbial keratitis, whether it is a suture or it is contact lens solution, contact lens case, all of them should undergo culture and sensitivity. And in at least twice negative smear and culture, no clinical improvement, one can do corneal biopsy, which is done as partial thickness trepanation. The tissue is removed, end block, bisected, and sent for culture and sensitivity. So for mild ulcers, less than 3 millimeters in size, not involving the visual axis, it is fluoroquinolones which can be given. And if it is moderate ulcer, more than 3 millimeters involving the visual axis, then you have to give a combination therapy with cefazolin and tobramycin, or with cefazolin and ciprofloxacin, so that cephalosporin covers for gram-positive cocci and aminoglycosides cover for gram-negative bacilli. Important thing is that you have to give loading dose around the clock, which means even during the night time for the initial 48 hours, and then assess the clinical response. This is, I just put it how to, make cefazolin 5% and tobramycin 1.4% concentrated, how to make it in pharmacy or in the ward. And sometimes you have to give vancomycin 5%, then this is a way to prepare it, and amikacin and trimethoprim likewise. Now, these were our 2 randomized control studies, which clearly showed that fluoroquinolones, whether moxiflox or gatiflox, have equivalent result when compared with combination therapy, especially in mild or early moderate ulcers. And both of them are RCTs, which involve 200 plus patients. Adjunctive therapy has to be given with cycloplegics, anti-glaucoma medications, and topical steroids, and systemic antibiotics for perforations, impending perforation, post-perforating injuries, scleral involvement, and when the organism is Neisseria or Haemophilus, because that can cause conjunctivitis, and that can also penetrate an intact cornea, intact epithelium. Now, the SCUT trial taught us few things, and that was that early use of topical steroids is useful, especially when the vision is less, when there are central ulcers, when there are deep ulcers, and in cases of non-nocardia keratitis and severe pseudomonas keratitis cases, which do better. So what did it teach us? Topical steroids may be started, provided the loading dose of antibiotics have been given for 48 hours and the culture sensitivity report is in hand. Steroid should never be started for nocardia, atypical mycobacteria, and fungal keratitis. So this is what was taught by the SCUT trial. So the response is good, the infiltration decreases, the symptoms become better, the AC reaction decreases, then it is favorable signs. But if it is not responding, then you have to look for other organisms and other factors which may, change the course of the disease. Whatever your culture sensitivity report, if your ulcer is responding, change nothing about it. But if it is not responding, then do review the culture sensitivity report and then change accordingly. Now, specific antibiotics for specific organisms. So for MRSA, it is vancomycin, which is given. For severe pseudomonas keratitis, ceftazidime. For mycobacterium fortitum, amikacin. And again, for nocardia, amikacin or trimethoprim, which can be given. Topical colistin, again, in very resistant, multi-drug resistant cases, and this is how it is prepared from the injection powder, and how it is mixed to get a concentration of 0.19% colistin eye drops. This is how your ulcer should heal, with a faint corneal scar. Each time, please do stain with the fluorescein, because that gives you a completely different picture. And these are the complications. You can have perforation, impending perforation, staphyloma, corneoiridic scar, etc. Coming to fungal keratitis, which is the most common cause of keratitis in our country. And Aspergillus is common in Northwest India. Fusarium is common in Southeast India. So geographically, you should know where you are sitting because that does change the organism microbiology. Of course, the classical features are dry, thick, raised texture with feathery margins, satellite lesions, endothelial plaques, fixed hypopyon, and abscess. And you can have dementitious fungi such as this with brownish pigmentation, which disappears when the ulcer is being treated. Fusarium tends to have a more severe course, deep extension and perforation, and yeast has a collar button-like configuration. This I've already discussed. 10% KOH is required in seborrheic dextrose agar. And sometimes when you think that it is a fungal ulcer and your microbiology doesn't prove so, you can do a PCR, which may come out to be positive, or you can do a confus scan, which may come out to be positive, and you can start your antifungal therapy in those cases. We've also demonstrated the use of anterior segment OCT. You can actually see when the ulcers are active, there will be a lot of necrotic areas and keratocytes which are active, which can be seen on the ASOCT itself. And also as it heals, they convert into a faint scar. 5% netamycin is the mainstay for a case of fungal keratitis. Again, taper 4 to 7 days if the ulcer is responding. If there's worsening, you can add 1% voriconazole. And therapy generally lasts for about a month, unlike in case of bacterial keratitis, which it lasts for 10 to 14 days. And here you have to wait for the response for about 4 to 7 days, unlike bacterial keratitis, where after 48 hours, you can assess the response. This is a case of Fusarium keratitis responded to topical netamycin. There are limitations of topical antifungal therapy because it's not because of poor ocular penetration and bioavailability. And the MUT1 trial did teach us that voriconazole should not be used as monotherapy in cases of filamentous keratitis, and systemic antifungals classically are indicated for large and severe deep ulcers, scleritis, post-PK cases, and endophthalmitis. We like to give ketoconazole or voriconazole, both in the doses of 200 milligram BD, and LFT should be done every 2 weeks. Now, this is a case which did not respond to topical netamycin, and so systemic ketoconazole was added. And MUT2 trial did show us that Fusarium keratitis may benefit from addition of oral voriconazole to topical netamycin. We did a randomized control study again where we showed that the levels of oral voriconazole are better than oral ketoconazole, and tear film concentration was also better, but in terms of the clinical response, there was no difference. Now, targeted drug therapy does have a role to play, especially when the ulcer is not responding and when there are deep anterior chamber exudates. You can give intracameral antifungal agents, which could be amphobi, which we don't give because it causes a lot of reaction, but we like to give voriconazole 50 to 100 microgram per 0.1 ml or intracameral amphotericin B. You can see that the ulcer has responded very well. And you can give intrastromal injections, especially if there's no response to conventional topical and systemic antifungal therapy for 4 weeks. And these were our first 3 cases which responded to the intrastromal agents. And then we did a randomized control study, which proved definitely that all those cases which did not respond to topical netamycin, you could add very safely voriconazole to it. So I think the August panel here is very well aware of how these injections are given after doing an AC parenthesis, washing away the exudates, and then intrastromally injecting along the lesion in 5 to 6 hemimeridians. This is voriconazole, 100 micrograms per 0.1 ml, forming a barrage, and you can repeat this after 72 hours if required. We did publish again in our randomized control study the TST protocol of the topical, systemic, and targeted therapy, and because it is all about algorithms today. So this is the algorithm of the TST protocol: less than 5 millimeters, 50% stroma involvement, netamycin. If there is no response, add topical voriconazole. But if it is more than 5 millimeters, more than 50% stromal involvement, add systemic, which could be a ketoconazole or voriconazole. No response for 2 weeks, add topical voriconazole. No response for 4 weeks, come to targeted therapy, which could be intracameral, intrastromal, or both, depending upon where the lesion is. So this is our study, which proved the same. And the success rate with the TST protocol has increased to close to 80%. We are working on Netasol, and this is being taken up by Microvision. Very soon it is going to be available in the market. Natamycin is 5% suspension, and now we'll be calling it Natasol, which is going to be a clear solution. The pharmacokinetics are very encouraging. The peak is higher, remains plateaus for a longer period of time as opposed to the suspension. And this is one case of post-LASIK fusarium keratitis, intrastromal Natasol, which caused the resolution, which was in fact being planned for a penetrating keratoplasty. We have done comparative evaluation again in a RCT of intrastromal injections of voriconazole, amphotericin B, and natamycin. And these are 3 cases from 3 different groups. And what we found was that vascularization was more in those cases where we used amphotericin B as opposed to voriconazole or natasol. Natasol also works more effectively and much more quickly as compared to amphotericin B. So sometimes even when you do therapeutic keratoplasty, the ulcer recurs. Again, you can give intrastomal injections, and so this helps. Now you can do glue for cases whenever there is any impending perforation such as this. And this is the drape patch which is being used here, and followed by a bandage contact lens application. And another very large case came during the COVID times, no tissue, so was glued. And we were able to save this eye. Of course, you can do DALC in cases where you, as a single stage procedure for visual rehabilitation, as well as for tectonic support, and these cases do well in a single stage surgery, and viscoelastic can be used for the same. And this is a case of post-epileptic keratitis for which a therapeutic keratoplasty had to be done. We were able to save the eye. This is the same eye on the operation table, and you remove all the necrotic tissue, and then you use a large graft, which is about 0.5 to 1 millimeter larger than the area of the infiltration, and then suture it with 10-0 monofilament nylon sutures after giving a wash. Which in this case, we use intracameral vancomycin and voriconazole both, because this was a mixed infection. So a large graft was used, and we were able to save the eye. So these are our articles in current opinions in ophthalmology, review articles, and in survey of ophthalmology, which gives it all if you need to know the details. And our second edition is ready, which will be coming very soon. And thank you very much for your kind attention.
Thank you, ma'am, for that wonderful talk. I'm sure the audience would have loved it. If there is one single thing that can be taken from your talk, almost everything was very important. But one single thing that can be taken from your talk, I think it's the TST protocol. The audience is listening. I think you should rewind the YouTube video, pause there, take a screenshot, and stick it in your opening. I think that's the single most wonderful contribution that you've done. And I think more are yet to come. The Natasol, I think, is going to be a game changer. All the best to you, ma'am, regarding that. And we have a lot of time actually left. Before we start presenting the algorithm, we can go about a little bit of discussion. And what do you think about the stud trial? How seriously do you take it? I was not taking it seriously until very recently, when I reluctantly started using steroids in my culture positive cases. So I found the results to be wonderful, especially in large pseudomonas ulcers. It makes a big difference. What is the experience?
I completely agree with you, Prashab. As far as topical steroids in keratitis is concerned, I am a little more aggressive with that. I sometimes feel that we are so scared that we don't use it, and so sometimes we lose the game in that bargain, because we want to. If you have to take a decision of topical steroids, you should start it earlier rather than later. I completely agree, especially for severe pseudomonas keratitis, it should be done earlier. And once you are absolutely sure, like I said, that it is not fungal, it is not nocardia, it is not atypical mycobacteria, you have the culture report in hand, and you have overloaded the eye already with topical antibiotics, I think there is no reason why you should withhold steroids. Anecdotally, although I cannot say, but I do believe that The scars which are there, of course, the SCUT trial could not demonstrate that, but I do believe that the scars which are there are fainter as opposed to if you don't use the topical steroids. Why the SCUT trial could not achieve it was because perhaps in the inclusion criteria, if you see the SCUT trial and the MUD trial, the ulcer size is very small. Anything more than 0.5 millimeter has been included. Now, anything which is 0.5 or 3 or 5, all of them are going to have, different prognosis, and all of them are going to behave differently. So that segregation, I think, was not there in enough numbers. And I think we need to do that. I'm not saying you should use it for less than 0.3 millimeter, but you can safely use it for ulcer size, which is say 3 millimeters or more. And especially like the dictum that we follow for adenoviral keratoconjunctivitis, and I did not cover it there for the want of time, but the dictum that we follow there, that if you have those opacities in the center, I would want to use topical steroids. So likewise, I would want to use it here, because you don't want a big scar in the center of the cornea, because then the patient is losing the best corrected visual acuity. So I completely agree with you, and I am, I am aggressive with steroids. Then I do not like to give FML or Lotepred, whatever the thing is, twice a day or once a day. That I think is a half-hearted kind of a approach. If you're doing it, then do it full on. I mean, fear nothing, of course, under supervision. And if you think that things are not going your way, you can always stop it. But if the patient is ready to follow up, compliant, go ahead and do it.
Thank you, ma'am. Dr. Anil, what is your opinion regarding SCUT trial using steroids in bacterial ulcers? You do it regularly?
Yeah. Am I audible now?
Yes, sir. Yeah.
Yeah.
Yes.
Even in the SCUT trial, the large infiltrates, I think steroid group fared better. So I think especially gram-negative ones, when the infiltrate is there and a lot of edema is there, I will start steroids within the visual axis, provided I have the culture report with me. But that's something that is to be double underlined, as Madam was rightly mentioning, I think whatever the infiltrate that you're seeing on the cornea, it's just mainly it is your neutrophils and other cellular agents. It's not the infectious organism per se. So you can at least take care of it to a certain extent by giving steroids. So I think if you have a culture report with you, and if you are pretty sure about the diagnosis, I think we should give steroids, especially in large ulcers.
The other thing I would like to ask the ma'am is in your studies, the intrastromal and the intracameral voriconazole seems to be working. Why is it that the topical voriconazole does not work and the intrastromal or intracameral works more? Because the voriconazole is supposed to have good penetration.
So I will say it like this: like you have combination therapy for bacterial keratitis. And I think we've completed that thesis already and also analyzed our data, and that will be going for publication very soon. I feel a combination therapy of topical natamycin and topical voriconazole works better than topical, natamycin alone. And that is we actually did the study in 3 groups, and even our RCT, which we did, we took cases which were recalcitrant and did not respond to natamycin. And then in one group, we added topical voriconazole, and we found that those cases responded. And the other group, we gave intrastromal injections, and we found that even those groups responded, although there was no difference between the two per se. So I feel that when you give a combination therapy in fungal keratitis, then it works better than a single therapy. Of course, single voriconazole, like I said, Mutt very clearly said that don't use it as a primary therapy, because it doesn't work that way. So in a combination, I think it works, whether you combine it with intrastromal voriconazole or you combine it with topical voriconazole, vis-a-vis if you give only topical natamycin. And this is for all those who are not responding to topical natamycin. Another promising drug which I didn't cover because there's not enough data is caspofungin. So sometimes when it responds to nothing, then caspofungin. Now I have a series of almost 35 cases, where caspofungin has done well. Only thing is you have to prepare it in pharmacy, and it's an expensive drug.
But it's available. It is available.
Yeah.
Information for all of us. I think we are ready with the algorithm. If Dr. Anjana is there.
So nice to see Anjana, our alumnus from RP Center, Anjana.
As ma'am said, she's an alumnus from RP Center, and she's a cornea consultant at Chaithanya Hospital and Research Institute, Bandram. And she will be presenting the algorithms, consensus algorithms regarding our 3 cases. Go ahead, Doctor. Please unmute yourself. Dr. Anjana.
Thank you, ma'am. And thank you, Dr. Prashop. Let's go on to the consensus algorithm. So in refractive surgery, what we have to keep in mind is high-risk characteristics. Now, the high-risk characteristic can be divided into patient characteristics and topography characteristics. Patient characteristics in ocular, we can consider allergy, eye rubbing, high myopia, dry eye. In systemic, we can take into consideration young age, family history of allergy, hypothyroidism, planned pregnancy, autoimmune diseases. In topography, it can be either a flap-based or a cap-based procedure. The important risk factors we have to consider is thinnest Paki less than 480 microns, RSP less than 300 microns, PTA more than 40, Kmax more than 47, inferior steepening, skewing of the radial axis. If there is co-location of the thinnest point, steepest point, and the highest point of elevation, if there is high posterior and anterior elevation, abnormal PTI. And in Pentacam and Sirius, there are various indices which we have to look carefully before going to decide on surgery. So when a patient comes, if the patient has normal topography with no high-risk characteristics, we can proceed on to a procedure of our own choice. Where we have to be cautious if the patient is having frank keratoconus, very high myopia, very thin corneas. I'm sorry. Very thin corneas or severe dry eye, we have to avoid refractive surgery. In very thin corneas and in high myopia, we can consider phakic IOLs. So, and when to repeat and observe. That is when a patient has borderline topography with one or more high-risk characteristics, or if there is active allergy, we need to treat the allergy. If there is ocular surface disease, we have to treat the disease and then again repeat topography and take into consideration the factors again. When the patient has borderline indices with no high-risk characteristics, or when the patient has normal topography with high-risk characteristics, we have to proceed cautiously, lean more towards surface ablation and maybe extra procedures also. So in peripheral ulcerative keratitis, whenever a patient comes, we have to look for the history of autoimmune diseases. If the history of autoimmune disease is present, we have to look for the systemic features of various autoimmune diseases. We have to look for the ocular features also. It includes scleritis, corneal infiltrates, and dry eye. If corneal infiltrates are present, we have to keep in mind the suspicion of secondary infection and do a corneal scraping and culture. The scraping and culture is as positive, we have to start fortified antibiotics. If it is negative, we can go ahead with lubricant, steroids, and prophylactic antibiotics. And investigations we have to do for systemic investigations should be done. If it is present, we have to start systemic immunosuppression. And for the patient in follow-up, we have to watch for recurrence. We have to carefully monitor for the side effects of systemic immunomodulators. We have to look for complications like perforation, corneal thinning, astigmatism. And if there is progression, we can step up immunosuppression. And at any point, if necessary, we can proceed on to surgical management. For a dry eye patient, whenever a patient comes, there is an importance in asking the triaging questions, as Dr. Rohit had clearly demonstrated. We can use various questionnaires like OSDI, DEQ, modified questionnaires, McMoney's questionnaire, and with special importance given to the psychology part of the patient, so that we can understand the psychological aspect of dry eye also, which is a very upcoming thing, as Sir has pointed out. We have to do the risk factor analysis, which is well described in literature. It can be divided into constant, probable, and inconclusive. We have to proceed on to dry eye testing. Also, along with dry eye testing, we have to keep in mind the testing of convergence and accommodation. And if any abnormality is present, we have to manage them accordingly. With the dry eye testing done, we can categorize the patients based on symptoms and signs. If the patient has signs of dry eye but no symptoms, we have to keep in mind dysfunctional nerve sensation. If the patient has no signs, then we'll consider the patient as normal. When the patient has symptoms of dry eye with positive signs, we have to categorize the dry eye patient into aqueous, mixed, or evaporative. And if the patient has signs of ocular surface disorders, we have to treat the ocular surface disorder and proceed on to management accordingly. Now, there is an entity where there are symptoms are present, but we get no signs. We treat it as neuropathic pain. We have to observe and give the preventive therapy, and various modalities of therapy has been already described by our esteemed panelists. Thank you.
Thank you, Dr. Anjana, for reducing the whole discussion into, it's very difficult to put it into one slide, but you have done it very nicely. Just one caveat to our audience, that this is an algorithm that's based on evidence, and whatever evidence is that is available today and our expert panel's opinion, please do modify it according to your own needs. Each individual patient is different. There is no one single algorithm for every patient. So please do modify it according. This is not binding. This algorithm is not binding in any case. Finally, we are coming towards the end of the session. I would like Dr. Namrata Sharma to give a final word, the final summing up, if you will. Dr. Namrata.
Thank you, Prashobh. I think it was really done very well, and it was done in a different style completely, something that is really required. Anjana, I think I must congratulate you for making such excellent algorithms, and some of them I realized that you picked up after we have spoken. So thanks for doing it, and thank you again for I think it's a great idea to have this program on management algorithms. This has given me ideas that we should have these management algorithms for all diseases, and should be doing it at a national level also. I'll take your help, Prashobh, and everybody here to make it happen, and I'm sure
Always.
Thank you so much again, once again. Thank you, Dr. Sahasramam, Dr. Prashobh, Dr. Unni Nair, for having me here again.
Thank you all. I think we had a wonderful, vibrant discussion and case presentation and the algorithm presentation. So I think we have finished ahead of time as well. So thank you all speakers for sticking to time. And I think we'll move ahead to the next session, which is Retina. So I'll hand over to the moderator of the next session. Thank you.
Thank you, Dr. Prashobh, and all the faculties for that insightful discussion. That brings us to the end of the Cornea session, and now we'll move on to the second session of Synoptic, that is the retinal and uveal diseases. I humbly request Dr. Manoj S., Senior Consultant of Vitreoretinal Services at Chaithanya Trivandrum, to moderate this session. Over to you, sir.
Thank you, Dr. Meru. So let's move on to the second session for the day today. The second session is on retinal uveal diseases, and the first part of the session we will try and cover retinal pathology, and this will be followed by the uvea session. So, for the retina session, we have with us an elite panel. We are extremely happy to have have with us some of the young thinking minds in retina. Dr. Jay Chaplani has joined us from Pittsburgh. We have Dr. Abhishek Kothari, who's joining us from Jaipur. Dr. Daresh Shroff is joining us from New Delhi. And our own KSOS faculty, Dr. Prakash, who's joining us from Commerce, Calicut. In this session, we will be having a keynote address. This will be followed by 2 cases, which we will be discussing with the panel. And this will be followed by the UVS session. So first of all, I'd like to extend a warm welcome to all our panel. And let's slides. So we'll start off with the keynote address. Dr. Jay Chaplani will deliver the keynote address for this session. Dr. Jay Chaplani requires no introduction. He's currently a faculty at the Pittsburgh Eye Center, Pittsburgh. And he's done his VR training from Shankar Nethralaya, and then he did his ICO fellowship at Switzerland, and he was initially faculty at the University of California, and then later at L.V. Prasad Eye Institute, Hyderabad, and now recently has moved to Pittsburgh. So he's a prolific publisher, and he's got more than 420 articles in various journals. He's a much sought after speaker. You hear him in every other retinal conference these days. And he's a recipient of numerous awards. And he's also on the editorial board of many international journals, including the American Journal of Ophthalmology. So Dr. Jay, I would just invite you to deliver the keynote address. He's going to talk on a very revolutionary topic, venous overload choroidopathy, which I believe is going to give us a different perspective on the pathogenesis of various choroidal disorders that we deal today. We're looking forward to hear from you. Over to you, Dr. Jay.
Thank you, Manoj sir. It is always a pleasure to be part of the team. Can you see my slides?
Yes, Dr. Jay.
But are they in the? I'm still not seeing them in the slideshow. Okay, there you go. Okay. Thanks a lot. And I did not get chance to attend the Cornea session, but I could hear just the algorithmic part, and it was really impressive. And I think, as always, Chaithanya is coming up with a different approach to the CMEs, which I have always enjoyed. Great. So I'll be talking about venous overload choroidopathy, a pathophysiologic model. And as Dr. Manoj was explaining, that this is something new and we are like thinking differently right now. So I would say it is not actually advanced. It is stepping back and looking at the same things what we have been working on. These are my financial disclosure. None of them are relevant to this presentation. So I'm sure that most of you have seen these wide field ICG pictures, which is becoming more and more common. However, it is not easily available to perform a wide field ICG, but these are some of the pictures which we published in our recent paper. So just start looking at these pictures and you are seeing that there are multiple choroidal vessels. The yellow lines and the white lines, they are showing the watershed zone. You can see that each quadrant has their own choroidal blood vessels and they are going to the vortex ampulla. But I would like you to just look carefully on this picture particularly. You will see that unlike a typical blood vessel, which is what every blood vessel follows a concept called Murray's law. The Murray's law says that the branching to the blood vessel helps for the better conduction of the blood, which is the most efficient way of supplying blood. This is what happens in the retinal vessels. You can see that the retinal vessels have a lot of branches, similar way the retinal veins have these branches, they merge together and do it. But stepping back and looking at this picture again, you are seeing that these choroidal vessels which are starting somewhere in the posterior pole, they all are parallelly going towards the ampulla. You are not seeing much of branches, but you can see that these vessels are independently traveling towards the ampulla, and this is what makes the choroidal vessels very unique. So they do not follow the Muret's law. That's why they follow parallelly towards the ampulla, and the reason for this we are still uncertain, but this could be just to bring down the heat or the temperature, as well as to become more efficient for the choriocapillary supply, which is what we believe that this is supplying a particular lobule, which is what these blood supply is helpful for. Let's look at the IOP concept of the pressure and the pressure in the choriocapillaries. If you understand that the pressure in the vortex vein is 3 to 4 millimeters of mercury, and the choriocapillaries pressure is slightly higher than the veins. And so what do we expect? We expect that if the IOP increases, the choriocapillaries should start blanching, the vortex vein should blanch, and everything should stop. An increase in IOP does not happen not only in the acute angle closure glaucoma, but for us, it happens even during the scleral buccal surgery. And we know one of the papers long ago showed that the intraocular pressure increases around 200 millimeters of mercury sometimes during the scleral buccal. So do we see any blanching of the vortex vein? No. Why does that happen? Because when the pressure in the eye increases, simultaneously there is an increase in the pressure in the choriocapillaries as well. And to bring your attention that vortex veins behave exactly like our self-sealing vitrectomy incision, as you can see on the lower left. So whenever there is an increase, there could be a blockage over there. But usually we do not see this blanching. I'm just throwing these concepts. We will put this together and understand what is venous overload choroidopathy. So we understand that whenever there is a venous overload, the retina shows venous dilation, vascular tortuosity, macular edema, and we see central retinal vein occlusion. What do we see in choroid? We see serous detachment of the retina, choroid, and sometimes ciliary body detachment just because of venous overload. And we do expect sometimes angle closure glaucoma and transient myopia. These are the features we are aware of venous overload effect on the retina and choroid. I'll take you a little bit beyond this. This is the very interesting case report which was published way back in 2015 from a patient who had heritable pulmonary arterial hypertension. And you look carefully, you are seeing something similar what we just discussed, even in a patient who had pulmonary arterial hypertension. So now you can see that how the choroid is linked to the pressure in the body, or I should say an arterial hypertension or systemic link. This does not end here. This is the choroidal changes which were seen in a patient with carotid cavernous fistula, and you can see that how these vortex veins are showing so many changes, anastomosis, and this is what we are now seeing in patients with venous overload choroidopathy. This is where the terms are starting, where you can see that whenever there is where in this patient of carotid cavernous fistula, you are seeing almost similar changes. What do we see in CSR? These are some of the ICG pictures from CSR. You can see that what I showed you as the first picture does not follow this at all. You can see that how these vortex veins are making these anastomosis. There is so much going on along the choroidal vessels. They are not following the typical watershed zone, and there is a lot of intervortex communication going on. Another picture from a patient with CSCR. You can see something similar where you can see that vortex veins are, the choroidal vessels are not following the pattern what we expect them to follow. This is another picture which was reported by Speed in one of our recent paper, where they showed that by doing the binarization, you can see these choroidal vessels so clearly, and you can understand that this communication is playing an important role in patients with CSCR. Let's not forget about the role of sclera. Sclera plays a very important role for fluid passage through the sclera. We know that if the arterial pressure increases or venous blood pressure decreases, there could be a decreased fluid exiting through the sclera. And now you look at the picture of B and C, these are the pictures which show that if the sclera is thickened, there could be a further decrease in the fluid. And you can see that how we have showed that the venous engorgement is seen as soon as in patients with thickened sclera, where the fluid is not able to pass through. That's why the choroidal veins are increasing. And that's why you can have some fluid accumulation there as well. And this is what eventually leads to the choriocapillaries damage. So, but do not forget that there is no lymphatic vessels in the choroid. And if there are, it is very rudimentary. They are not helping at all to take away the fluid from the choroid. So if these features we put together, you will realize that how this all makes sense together. When we put this thing together, that is where the concept of venous overload choroidopathy comes. Let's start from the bottom. Intrinsic or extrinsic effect on the venous loading, which eventually increases the venous pressure. What we see in our angiography is the venous remodeling. We have enough and more papers now showing the intervortices anastomosis in patients with CSCR and even PCV. And this all is leading to the increased choriocapillaries pressure loading. What happens next? There is a decreased perfusion leading to RP damage, choriocapillaries damage. There could be leakage through the RP, which presents to us as a subretinal fluid because the sclera is not able to allow the fluid to go away. So where the fluid goes, it goes in the subretinal space, considering the choriocapillaries damage and the RP damage, which is subsequent to the venous pressure increase. So this is where the concept of venous overload choroidopathy comes. I would say that the story does not end here. We need to learn a lot. What we still do not know is that we do not have much information about the intervortex vein anastomosis in health and disease, because we still have very limited literature and the wide field ICG of our patients. So we are yet to learn about this. But what is the implication of coming up with this newer concept of venous overload choroidopathy? What are we planning to do with our patients? We can consider vortex vein decompression, and I'm sure that most of you are aware that there are papers which have shown that doing scleral windows, people have tried in patients with chronic CSCR and showed some early results, and these have been very satisfactory as per those papers. We already know that the scleral thickness is more in patients with CSCR, and in the anterior part, we are still uncertain what is going on in the posterior part, but we believe that the sclera could be thickened, and that is where the vortex vein decompression could come by making these scleral windows. What else can we do? We can consider redirecting this venous flow, as we saw in many of these patients that some of the vortices were pretty much enlarged because probably the venous flow is quite a bit. So can we actually redirect this flow by performing more destructive laser, kind of laser to choroid? We still don't know whether it is even feasible in our patients or not, and what is the impact of such laser on the retina. But we have to think aloud and start looking into much deeper rather than just treating one area of leak by doing a focal laser or performing a PGT. There is a bigger problem going on underneath, which we are still uncertain. With this, I would just request you that I'm sure that I have confused most of you more. So if you want to read more about this, this is one of our recent papers which we published as a group with Speed as the first author in progress in retina and eye research. This is a newer concept which we hope to take this forward and make our patients a better management. So before I really close, I found something really interesting. And when I look at this Dunning-Kruger effect, which talks about if you really know more, you are actually knowing nothing. So I believe that we have just crossed the peak of Mount Stupid with the help of aggressive imaging. And now we are in Valley of Despair, and still the slope of enlightenment is far away. So we have a lot more to learn about what is going on in the choroid. With this, I would like to thank everybody for your attention. Thank you so much.
Thank you, Dr. Jay, for that wonderful talk. I thought we were in the slope of enlightenment, but then you actually brought us back into that trough. Anyway, it was a good talk. I think it probably gave us a new insight into the pathogenesis of various choroidal disorders. and it seems like an exciting concept. Thank you, Dr. Jay, for again for being part of this meeting and for making that wonderful presentation. We'll now move on to the case discussions. So we have two interesting cases for discussion. We have with us Dr. Shira Arun. She's a consultant at Chaithanya Trivandrum, and we also have Dr. Rahul Menon from Chaithanya Ernakulam, Cochin, who will be presenting the cases. So I would like to request Dr. Shira to go ahead with her presentation of the first case.
Yes, sir. Is it audible, sir?
Yes, we can hear you.
Yes, Dr. Shira, you can go ahead.
So, very good evening to all. My presentation is on a case of diabetic macular edema non-responder. So it's about 61-year-old lady with a history of diabetes, hypertension, ischemic heart disease, status post angioplasty, and with a history of stroke and rheumatoid arthritis. She is also giving a history of focal laser both eyes in 2014, 4 years back. And she underwent cataract surgery in the right eye 2017, which was an eventful surgery. And in the left eye, she underwent surgery in 2014. On presentation, her best corrected vision in the right eye was 636 N24, and in the left eye 69 N6. Anterior segment examination showed pseudophakia in both eyes, and right eye examination showed PC dehiscence and focal posterior synechiae. Intraocular pressure was normal in both eyes. Her dilated fundus examination showed moderate non-proliferative diabetic retinopathy in both eyes, with right eye having succinate hard exudate in the paramacular region. And there was focal laser marks visible in both eyes. This was her OCT scans taken in both eyes. In the right eye, there was vitreomacular adhesion with traction and cystoid macular edema with a central large cyst and moderately reflective contents. And there was a hyperreflective foci with back shadowing suggestive of hard exudate clumps in the paramacular region, parafoveal region, and her central foveal thickness was 723. The last image, which showing OCT scan passing through the fovea in the left eye, there was epiretinal membrane, and there was foveal thinning and extrafoveal focal ellipsoid zone loss. Her blood parameters were suggestive of anemia, and her ESR was elevated and ANA was positive. She was a case of rheumatoid arthritis also, and her HbA1c level was 12.5 with normal renal parameters. Her fundus fluorescein angiography of the right eye showed microaneurysms and macular ischemia, and there was diffuse leak around the macula, which showed a florid pattern in the late FA image, and dynamic FA showing pulsating lesion supratemporal to the fovea, which was suggestive of macroaneurysms. Her left eye FFA showed microaneurysms with focal leak temporal to the fovea, and we can make out the scar migration, which is post-focal scar lesions. Actually, at this point of time, we advised intravitreal anti-VEGF injection in her right eye, but she didn't turn up for that. And she presented again after 12 months without any treatment. At that time, her vision in the right eye was remained the same, 636, and left eye reduced to 612 from 69. And her intraocular pressures were normal. But in that visit, her renal parameters were deranged. Serum creatinine was 2.8. She underwent 4 intravitreal anti-VEGF ranibizumab injections over 8-month time, and her vision remained the same, 636. And we can see the serial OCT scans. There was the cystoid macular edema persisted, and in the later scans, we can make out the turbid cysts in the foveal region. Since her serum creatinine levels increased, nephrologist advised to consider change in anti-VEGF. So she underwent next Ozurdex injection, And following that, added focal laser. But her vision remained almost the same, improved a little bit, 624, but the systolic changes were reduced only a little bit. So now the case is open for discussion.
Thank you, Dr. Sheera, for that great presentation.
Thank you,
now I'd like to engage the panel for a short discussion. Let me just start off with Dr. Jay. Dr. Jay, how would you define a persistent CME or a non-responding CME? And what would be your definition?
This is very important question, and one of the guidelines which we have established for Asia Pacific diabetic macular edema group, we did come up with a definition of non-responder DME, because this was never ever evaluated, and most of the literature from the West was supporting 6 injections, but we wanted to come up with that if you do not see any change in improvement, when I say any change, it should be less than 10% in change in cystoid macular edema in the central retinal thickness, and less than 5-letter improvement or change, we will consider this as a non-responder after 3 injections. So I usually start thinking that I need to switch after 3 injections.
Why I ask you this question, because in practice, at least in India, we realize that now most of our patients, they are not very compliant for these injections. We don't get to see these patients often, and we often end up treating them on a PRN basis, and then to define non-responsiveness becomes very difficult because you're not seeing them on a monthly basis.
Sorry, I think one of the caveat which we still do not address is that how the patient presented to you. What if the patient had DME and you are seeing the patient for the first time, he never received an injection, and you are already seeing chronicity on the scans, and now you start with your first anti-VEGF and expect it to respond in 3 or 4, it does not really, it becomes very challenging. So I think this is something which we really need to come up with, that what do we see at the baseline and how is the OCT looking at us? There are situations where patient has never received a single injection and he's presenting to you for the first time. So I think this is one thing which is still lacking in the whole scenario.
Yeah, very true. Dr. Abhishek, can you just throw some light on what are the biomarker clues that you use? Dr. Jay was just mentioning about the disease being chronic. So how do you decide on that? I mean, do you go by an angiographic evaluation, or do you do an autofluorescence, or do you still rely on OCT biomarkers?
No, we of course do both. I mean, angiogram and autofluorescence does tell you about the status of the RP in a chronic diabetic macular edema. But on the OCT, you can very well make out if the macular edema has cysts that are wider horizontally than they are vertically. That basically means that it's almost like a schisis that is happening, and that is something that I would consider as a biomarker for chronicity. Of course, on the fundus photo, on your clinical examination, and on the OCT, if you have a lot of hard exudates with shadowing, there is also a sign that there is some kind of chronicity. A lot of the diabetic macular edemas do develop a thin membrane, on the retina, and an epiretinal membrane, along with these large number of large cystoid spaces. Again, sometimes like I said, that the horizontal diameter is the ratio of the horizontal to the vertical is skewed in this in the direction of the horizontal diameter. These are kind of I would say biomarkers, and in the case that was presented, you saw that the central large cyst was the kind of what I would call the septa in the cyst, they start to break down, and it becomes like a coalescent cyst. Now, these are things that they would tell me that the edema is not short-term at all.
And the other thing that I wanted to ask you, Dr. Abhishek, is like, see, here we started off with anti-VEGF, and then we switched over to Orthodex. So, in your practice, when do you start off with Orthodex? I mean, when do you start off with steroids? Does again, do you really go by biomarker? You look at the biomarker clues, or do you look at you initially give them a trial of anti-VEGF and then decide to switch?
No, it would actually depend upon the complete situation. Like Jay said, if it's a pseudophakic patient, my tendency to go with steroids is a little higher. If the baseline diabetic retinopathy, if I see that it's a severe or a very severe NPDR, I would probably think of an anti-VEGF. But if it is a moderate, sometimes we see a good amount of macular edema with mild to moderate NPDR also, then I would think of a steroid sometimes in the beginning also. In the setting of a diabetic macular edema that has been exacerbated by cataract surgery or a recent intraocular surgery, I would definitely go for an Orthodex in the very beginning rather than going for anti-VEGF. But apart from these special situations, yes, if it's a phakic patient, if it's a middle-aged patient, which is the most common, I would say, demography of our diabetic macular edema patients, yes, anti-VEGF would be the first choice.
Dr. Prakash, so this patient, we started off with a HbA1c of 12. So and then the patient also had anemia. Do you really look at these factors when you start patients on anti-VEGF therapy? Do you really want to bring down the HbA1c or treat the systemic conditions first before you start the anti-VEGF therapy? The question is because the trials are a little confusing. You have the RISE and RIDE trial, which talks about HbA1c, not being very important. The Vivid and Vista trials talking about the converse.
Yeah, Manoj, actually, the problem is getting HbA1c under control will take a lot of time. So I would look at only the sugar at the point of time of injection. If it is well controlled, I would go ahead with injection. But having said that, anemia correction, I may not wait for anemia correction. Anemia definitely is going to make this patient a poor responder. But what is important is the systemic status of this particular patient. If you look, there is EVA, there is IHT, there is a rheumatoid arthritis, and there is elevated marker of inflammation, ESR, and then there is anemia. And in the absence of a renal disease, because your creatinine was normal at that time, in the absence of renal disease, if you see a low anemia, it could be anemia due to some blood loss, occult blood loss, but also you should do a proper workup for the anemia, because anemia is most of the time most underworked up or undertreated condition in diabetic patients. So anemia, if most of the time, as I told, MCV or HC will tell you whether it's an iron deficiency anemia, but if it's not an iron deficiency anemia, you have to think of other causes that cause anemia in diabetic patients, like multiple myelomas or other gamma globinopathies and all. So that workup also has to be done. So evaluation of anemia is very, very important, first of all. And second thing, I wouldn't have started with anti-VEGF in this patient because of all the systemic problems. And as Dr. Jay pointed out, the cysts are showing degenerative changes. To add to few points to that cyst is actually, if you see large cyst with not a circular shape and extending the full thickness of retina, and exactly beneath that you can see ellipsoid layer loss, which tells this is a degenerative cyst. So we are from the beginning itself with all the systemic problems, anemia, I am sure this is not going to respond to anti-VEGF. So if at all you want to do, the best thing would have been to just to treat the leaking aneurysm and probably a steroid.
Okay, thank you, Dr. Prakash. And Dr. Darais, about the PCR status. I mean, this patient also had a rent. Do you think that is going to influence the way in which we manage DAP? You're muted, Darais.
Can you hear me now?
Yes, Dr. Darais.
So 2-3 things is an interesting question. One is PCR becomes a major issue, especially if you have a aphakic patient where Ozurdex is involved, because that is one situation where aphakic patient without a capsule which is intact, we would not like to inject Ozurdex. At least in my experience, we can take the panel's opinion. And secondly, I think what is important is that would definitely be, if there's a vitreous tag or something, that could definitely be a case where there's chronic inflammation happening. As I think Dr. Prakash has noted, this is a patient who is got rheumatoid arthritis, high ANA, all the other things are in favor of there being an inflammatory pathology also. And as Jay said, that chronicity is an issue. So I totally agree with what has been said till now. And I would say this is a candidate definitely who I would prefer steroid therapy, considering all these factors and including this PC status. My question to everybody else is, seeing the way that the traction is, the vitreomacular traction is, would you be more comfortable with a steroid and an anti-VEGF just in light of that ERM? So that is something also we will discuss.
Yeah, Dr. Abhishek, any comments on that?
I think, I don't know how significant that VMT is, because it doesn't look like a tense, kind of a connection between the vitreous and the foveal apex. The ERM will definitely hamper the resolution of the macular edema. There's no doubt about that. And I mean, in this patient, yes, like Dr. Dara said, it's not going to make a difference whether the PC rent is there or not. I mean, we treat the diabetic macula, but yes, I would again probably think that if there is a PC rent, and I think she mentioned that there was a peripheral synechia also. So these two factors would point that probably the inflammatory part, the inflammatory mediators would be on the higher side, and probably Ozurdex in the beginning could help. If not a combined, if not a combined one, then maybe alone Ozurdex could also make a difference. Yeah.
And Dr. Naresh, how about macular ischemia? I mean, how do you really modify your anti-VEGF plan, or like when you see a patient macular ischemia, how do you go about managing patients with DME and macular ischemia? That's one thing. And another question that I really want to ask you, I know you are using a lot of Opta these days. Most of us are using a lot of OCT angiograms these days. Do we really look at these quantitative data, that much during every visit? I mean, is it really useful in practice? Do you really use them in practice?
So I think basically the Opta, I think we don't really use quantitatively in every case like that. But important question about the macular ischemia is that I think initially when the original articles came out, there was a lot of talk about if there's a lot of ischemia, avoid anti-VEGF, and anti-VEGF can make ischemia worse. But I think practical experience has shown that is not really the case. The value of the macular ischemia is when you do a FFA and you find there's so much ischemia, you must prognosticate to the patient that the vision will not improve. But it does not really hamper the therapy as such. Even if there's macular ischemia, I don't think we'll hold back from giving an anti-VEGF agent or a steroid. I think that is an independent question, but I don't think that is going to hamper us. But the importance is that still we need to do a FFA, and now Opta is definitely showing us beautifully the ischemia, the macular ischemia. So prognostication, yes, I agree with you, it helps a lot. But at every visit to do quantitative Opta just to titrate it, I don't think the technology is yet evolved enough to help us with that. I think it just gives us kind of indication, but it doesn't tell us what to do.
Okay. Dr. Prakash, you want to make a comment on that?
No, I don't look at actually macular ischemia. That is an enlargement of an FSZ on angiography. But if OCT shows degenerative changes suggestive of ischemia along with that, along with an enlarged FSZ, probably like drill changes or like a cystic degeneration like this, cystoid degeneration like this, I would be a little hesitant, or I would at least explain the patient poor chances.
Okay. And Dr. Abhishek, have you got any experience with micropulse? I mean, how often do you use micropulse in your practice? And the other question that I wanted to ask you is that if many times we are not really doing enough focal lasers these days. I mean, sometimes the patient get lost in this anti-VEGF, injection after injection. We sometimes miss out on these add focal lasers. So I mean, how often do you do that in practice?
Right, so they're very, very relevant and a very important point that you raised. I don't have personal experience with micropulse, and I think there are very few people in India who would have substantial experience. But there are papers that report there is some kind of an improvement in the RP function with micropulse. I don't know whether or how effective it is. As regards focal laser, I do it very frequently. It's not infrequently that I do it. And the reason is not, I expect new microorganisms to crop up and I expect them to leak. But the point is that if you have these micro and sometimes macroorganisms that you can laser and ablate, the number of injections and the pace at which the edema comes back between injections, the interval between injections can definitely be prolonged. And that adds to, a reduction of the economic burden on the patient. And once that happens, then your compliance improves automatically. So eventually your results will, help. I would agree that theoretically, if you're giving a patient very regular anti-VEGFs, you may not really need to do these focal lasers. But that's not the case in the majority of our patients. Most of our patients do not receive monthly anti-VEGFs for a year or a year and a half. I don't think, I think each of us can count on the fingers of one hand patients that have received more than 9 injections or 10 injections in 1 year. So given that scenario, and given the need to, optimize therapy to reduce the number of injections and to increase the gap in injections, focal laser definitely has a role there.
Now, this is really important because in practice, what happens is when we have switched over to anti-VEGF, we're doing less angiograms these days. So what happens, the picking up these microaneurysms and even the new microaneurysms that we are talking about, that we are failing to do that. We are either basing it on the basis of Octa and then on the structural OCT, and therefore we may not have an opportunity to identify these new or leaky microaneurysms at the right time, and maybe we miss out on these ad focus. But as you rightly pointed out, that at least in our practice, we believe that adding focal lasers definitely brings down the number of injections and improves the patient compliance. Dr. Jay, you want to make a quick comment on this?
I think Jay has left.
Jay has a message that he has to back to you are.
Okay. So then I think one last question that I had is now how many of you, I don't know whether do you really believe this concept of RCMA, retinal capillary macroaneurysms? I mean, do you really think that this is really important? It has a bearing on the outcome of treatment of these diabetic macular edemas. In this patient, in the video angiogram, thank you, Shira, for showing that excellent video, where you could really make out those pulsating, feeder pulsating vessels to those aneurysms pretty close to the FAZ. I mean, they wouldn't amount to the typical retinal arterial macroaneurysm. They're pretty close to the FAZ. So you could consider them as RCMAs. And how often do you see them? Do you really give any importance to them, Dr. Darais?
So I think it indicates the severity of the disease and maybe the chronicity of the disease, that it's a chronic kind of a situation and is a severe disease. And I think maybe it would be a good idea to combine anti-VEGF with a laser to this. I frankly don't pay too much attention to it, but if I do find it, I may titrate on the part of combining, doing a combination therapy, in which I would always do anti-VEGF Ozurdex first. And when I feel it's quieter, the less angry, do a focal laser to the lesion. I don't know what you do, Dr. Manoj. How do you handle these cases?
Nowadays, the thing is that we find these RCMs quite common. I mean, I don't know, we were not seeing them before, but nowadays we tend to see them a lot more often in these patients. We try to look at one analysis where we try to look at this chronic diabetic macular edema and try to see if the incidence of RCMs were different. And we could not find a big difference. And then how do you go about treating it? I mean, I agree with you that the best way to treat them is by doing a laser photocoagulation. So maybe if I was worried about this fact that when you're doing too much Octas, we may be missing out on these large aneurysms which may not come up on the Octa. So now it makes when you have a persistent disease, it makes sense to do dye-based angiograms more often, so that you pick up these lesions better and then probably treat them earlier.
I think every 3 months or even every 6 months, if you do, it's enough. But I mean, what is happening now is it's never, which is not acceptable.
Okay. So we have one question from one of our YouTube. It's about how often do you do ILM peeling in diabetic macular edema? So that's a question. Does ERM removal or ILM peeling help in CME resolution? Should we consider early surgery probably in this patient? What is your opinion, Dr. Prakash?
I am not much in favor of doing an ILM because it might damage the already damaged inner retinal layers. So I don't do much ILM peeling, especially over the fovea at least. But all I do maybe a fovea sparing ILM peeling.
Naresh, when will you do an ILM peeling? Do you do an ILM peeling in all DME patients? And I mean, in chronic DME patients, when you want to do a surgery, do you do an ILM peeling always?
So I think quite some time ago, we had done our own in-house study on this. I mean, what we found is, although the macular edema really gets resolved very well after surgical intervention for diabetic macular edema, the vision results were not good at all. So it is unpublished data, but so we are. I would definitely prefer pharmacotherapy. And my feeling is, I don't know, this is also not really, and this is anecdotal, but so forgive me, but our feeling is that even if you do a surgical achievement of getting the cyst down, you're not going to really help the patient visually at all. So I agree with Dr. Prakash that I would not be in favor of surgically intervening in this case. I would prefer Ozurdex and even repeating pharmacotherapy. However, in case we do go in for surgery, we are now quite used to removing the ERM and doing a macular fovea sparing ILM. So like an inverted flap, you can just put all the ILM flaps together at the center, and that's the surgical way I would do it. But I would not be very, very keen to do that.
Yeah, especially in this patient with the macular ischemia, documented macular ischemia, it probably would not. We are not going to have a major benefit in doing an aggressive surgery. Yeah, I think we've had a lively discussion. I think let's move on to the second case. I'd like to request Dr. Rahul Menon from Chaithanya Cochin to make his presentation. Yeah, Dr. Rahul, you can.
Hello. Am I audible?
Yes, you are audible. Please go ahead.
So, warm good evening to everyone. Today, I will be discussing about an interesting and challenging case of CSR, which we have been managing for a while. So, this is a 53-year-old lady, non-diabetic and hypertensive. She had a history of CSR in the right eye 2 years back. The FFA pictures then indicated smokestack and ink block leak, for which laser was done. Now on presentation, the vision in the right eye was 624 and left eye was 66. The IOP and anterior segment was within normal limit. So this is the fundus picture. In the right eye, you have features of chronic CSR in the right eye, and left eye had features of some RP alterations nasal to the fovea, and we could see a PED inferiorly. The OCT showed some exudation in the outer retina in the right eye, subretinal fluid, a bumpy RP and pachy vessels. Also, the patient had features of schisis and PED in the other areas. So we did an FFA and ICG for this patient. So we could see areas of RP tract in the right eye and areas of hypoautofluorescence superiorly. The left eye had, in the area of PED, we could see variable hypoautofluorescence. The OCT of the left eye was completely dry. So in the FFA, we could see areas of increasing fluorescence in the superiorly, which increase in intensity over time. ICG did not see, we did not see any CNVM or any abnormal vascular network. Left eye had features of, showed some staining in the areas of PED. So we decided to do a focal laser to the area of leakage. So 3 months after the laser, the SRF in the right eye decreased. There was a persistent schisis, but now the patient developed SRF in the left eye. So since the patient had already underwent treatment for the same, we decided to start on the patient on spironolactone. 3 months down the line, the patient had a dramatic response. The right eye, the schisis had completely resolved, and the left eye SRF had resolved completely. Now, I'd like to bring to your notice, if you notice in the nasal area, you could see some schisis in the peripapillary region of the left eye. So the patient had developed some medical issues after which the physician actually decided to stop the spironolactone. And 2 months down the line, the schisis in the right eye recurred. Whereas if you also notice, the schisis in the left eye in the peripapillary region had increased. So we decided to do a repeat ICGA. In the autofluorescence image, we could see areas of hypofluorescence, autofluorescence in the superiorly. This was the area which we had treated previously. In the ICGA, we could see areas of hypoautofluorescence surrounded by regions of hyper autosinuses. So we decided, and the left eye was relatively normal. So we decided to take an OCT through the areas of hypersinuses, and we found there was some RP abnormalities in the region. So we decided to do a reduced fluence PDT for the right eye. So 6 months after the PDT, we noticed that the patient had developed increased exudation along the inferior to fovea, and also vertical imaging showed some area of suspicious area of greenish purplish tinge in the superior to fovea. And the OCT in that region, we could see in the choroidal slab that there was some abnormal choroidal vasculature. The left eye was relatively fine. So we decided to give a trial of anti-VEGF for the patient. So we injected 2 injections of ranibizumab in the right eye 1 month apart. After the 1 month after the injection, the right eye schisis was still persistent and the left eye was doing well. Also, at this time, we looked at the peripapillary region. There was a lot of schisis in the peripapillary region. So we were wondering whether if it was peripapillary pachychoroid syndrome. Also, since we have exhausted all our treatment modalities in the armamentarium, we decided to treat the case conservatively. So 4 months down the line, the patient again reported to us, and this time the schisis in the right eye had worsened, and also the patient had new SRF in the left eye. Since the patient did not complain of any much visual problems, she refused any repeat ICGA. 6 months down the line, after the injection, this was the OCT picture. The right eye still had persistent schisis, while the left eye subretinal fluid had spontaneously resolved. Now, since there was a natural resolution of the disease in left eye, we finally decided to continue the conservative management. Thank you, and I keep the case open for discussion.
Thank you, Dr. Rahul, for that case presentation. This is indeed a confusing case. Let's have a small discussion on this. Dr. Prakash, I'll start with you. When would you call a CSR atypical? I mean, do you really think this is a CSR patient, or is it something to do with CSR, or when do you call a CSR atypical? I mean,
yeah, first of all, any CSR in an older patient, like this case, above 50 years of age, definitely I would think of atypical. And this case, definitely we can see the pachychoroid vessels, all other signs of pachychoroid disease, but still we should think it as atypical because it does not show, even though there is a documentation of 2 years back having a focal leak, there is no typical leak right now. So I would think this as, so if you are clinically seeing in an older individual bilateral bullous detachments clinically, if you see exudates or intraretinal fluid may be present in CSR later on, but in early disease you may not see. And if there are hemorrhages or on FFA, you are not seeing the typical leak, or if you are seeing multifocal leaks bilaterally, all those conditions make you think, or if on the OCT shows multiple RP bumps, all those things make you think of this is an atypical CSR.
Dr. Abhishek, a quick comment on this?
Yes, I would agree that any CSR in an older age individual, that is, of course, the first and the foremost. The second thing is that when you have intraretinal fluid out of proportion to the subretinal fluid, of course, the one very important thing that I would like to point out here is if you look at the RPE layer, usually in a typical in a typical CSR, you may have a PD or but they are usually regular. The RP is straight or curvilinear, but here you have this bumpy RP, which again points to the fact that there could be something underlying the RP. So this is basically a choroidal exudation or a choroidal, I would say. I mean, we just had a talk about venous overload. I mean, if you want to label it as that, but the point is that there are a lot of images to process in the case, but if you carefully look at the images pre and post spironolactone, what has actually changed along with, of course, the disappearance of the fluid is that the RP, the bumpiness has reduced quite a bit and it became almost flat. So there is something happening at the level of the choroid here, which will, point out to me that this is not, I mean, I find it difficult to call it a CSR, especially, though these intraretinal fluid and schisis is known, it's a known entity happening in chronic cases of CSR, but to such an extent that there's hardly any fluid in the right eye, and I think if you measure it, the intraretinal fluid, the edema is up to about 700-800 micron it would come to. That is a little unusual. You always, all of us must have seen in chronic CSR having intraretinal fluid, or the typical intraretinal fluid in a CSR is what he showed in the left eye, peripapillary region. That is how usually it presents, not usually at such large quantities and in such a mountain-like configuration, especially in the absence of any subretinal fluid. So I would really relook at my diagnosis of CSR here. So atypical CSR is basically a basket term for a lot many probably entities.
Yeah, this patient actually started off with a typical, we don't have the old angiograms, but it started off with a typical, combination of ink blot and smokestack leak. I mean, that's how the diagnosis was made initially. But what is interesting is that, like you rightly pointed out, when the patient, when we saw the patient after the initial 2 years, the patient comes with a lot of intraretinal fluid. So I think one take-home message is that when you see a lot of intraretinal fluid, that we need to think of entities other than CSR. Though, as Dr. Prakash said, you could have it in chronic forms of CSR, and as Dr. Abhishek clearly mentioned that in at least in some forms like peripapillary pachychoroid syndrome, you could have it in the nasal papillomacular bundle region. Okay, now let's get on to the next question. In between, Dr. Darais, we also noticed that there is intraretinal exudation. I mean, how common is that in CSR? I mean, does that give you a different take on the whole pathological process? Do you think management should have changed at that point of time? Maybe like start off with anti-VEGF, or what is your take on that?
So, thanks. It's a very interesting case, and I think it's been a real challenge to manage this. So I am regarding the exudation, I have two takes. One, of course, it could be something what we have exudation with CMD. So basically the chronic fluid which forms in the macula, cystoid fluid spaces. But I don't know if you can see the images again, but along the superior-temporal arcade, if you look very carefully, and I think you guys have been giving us clues also to this, where he mentioned that a purplish kind of a lesion. If you see very carefully, I think if we do maybe a 3x3 octa there, we might find a network. So I have a feeling, of course, this is that whole thing about overload and the whole pachychoroid spectrum in its gamut being seen. And maybe what you mentioned, the first imaging 2 years ago showed the typical smokestack, etc. But now what I feel it is moved more towards neovascular kind of a issue. And that's what we are getting when we look at that particular area along the superotemporal arcade, and then the tracks which are coming down are probably causing that exudate. One of the multicolor showed the beautiful exudates inferior. So this is something which we definitely seeing. It may not be a full-blown PCV because the polyp is not very well demarcated, but I think there's a branch BVN in that area along the superotemporal. So I think we can have a relook at that.
Okay. And the other thing is, the other question, Dr. Abhishek, I wanted to ask you is about, do we always need to do an FA-ICG together? I mean, there was one instance now where we did an ICG, and then we were still looking for more clues, and we were not able to do an FA at that along with the ICG because the patient was allergic to the dye. So we were just thinking that if we had done an FA ICG, we would have picked up more information. I mean, is that true? I mean, in CSR, do you always need to combine FA and ICG? Because sometimes it's confusing. You have a lot of choroidal hypercyanosis, the hyperpermeability, that you sometimes fail to identify some of these more leaky areas. What is your take on this?
So I don't do it as a routine in all cases of CSR, and I don't think, I mean, I do a FFA always, I mean, because that guides our therapy, because it is directed towards therapy. But I would do a combined only in cases of atypical or non-responsive or a recurrent, multiple, if a patient has multiple recurrences, or it's not responding, or if it is, if it has other features of atypicality, if you will. So there I would definitely want to do, because I would want to synthesize all the possible information I have. One of the reasons that I would not do it as a routine is also that, like you said, sometimes you do get a confusing picture. You may think or you may pick up certain things which may not be relevant, or which you may not want to address, or which you cannot explain. So, and then you're stuck whether, in which direction you want to go to. Had you not done the ICG, you probably just done a focal laser and, sent the patient home. So it's like, it's a sleeping line. I would not want to disturb it, especially if things are routine. If on the OCT, the choroid looks quite okay, apart from just a few PEDs, and there is SRF without any much exudation, I would probably not do a combined ICG FFA. But yes, in a chronic case, multiple recurrences or atypical presentation, especially if I see the choroid the way that was presented in the case, I would definitely want to go ahead and do an ICG.
Yeah, I think what Dr. Abhishek was trying to say is that that even though CSR is primarily a choroidal disease, interpretation of endosanguine angiography, fluorescence is a little difficult, and therefore sometimes you could have issues with that. The next thing that I would like to ask Dr. Abhishek again is how often do you do autofluorescence? I mean, when you see a patient CSR coming to your clinic, I mean, do you do an autofluorescence always? I mean, or do you try and figure out if you think it's acute, you don't do, and then if it is chronic, you tend to do it?
No, 100% of the times I would want an autofluorescence. Because see, if you ask me, the way I treat my patients is that one of the most important characteristics is following the autofluorescence. It gives me the RP status. If I see that there is some RP damage, the patient may have come to me for the first time, and he may have had a second or third episode. If there is problem on the autofluorescence, then I would want to treat him earlier. So we all know that the downside of having an observation or keeping a patient under observation is RPE damage in a chronic CSR. So I would want to monitor. So every single time, and now we have our own software, which I work with a team where we have an artificial intelligence software that gives me the volume of the CSR. So there are only two things that I see. One is the volume of the fluid, and second is the RP status. If they are healthy, I may want to watch them longer unless the patient wants early treatment. If there is any sign on the autofluorescence of RP damage or sick RP, then I would intervene earlier.
Okay, thank you, Dr. Abhishek. Dr. Prakash, you'd like to make a quick comment on this?
Yeah, I definitely agree. Exactly what Dr. Abhishek told. I would do an FIF to detect early chronicity, and if there are signs of chronicity, then definitely go ahead, think of treating it aggressively. And the second comment I want to make is, like in this case, where you have the main question, why you want to know whether it is typical or atypical. If typical means we go ahead with only our typical set of investigations that we do for CSR. But if it is atypical, we have to think of masquerades either in the eye as well as elsewhere, especially a 53-year-old lady. And one more interesting thing in this particular case is the response to the spironolactone. Even though it was initial, there was a good response. So we have to probably do a serum mineralocorticoid assay or a cortisol assay, and probably an MRI also to rule out a microadenoma, secreting microadenomas in these cases. And One more thing I would do is probably if you have this patient, if this patient is obese, do a sleep study to rule out, as Dr. Jay was telling, this could all be part of the venous overload choroidopathy. So the venous pressure can be elevated in sleep conditions like sleep apnea. And so do a sleep study also in this patient if it is obese, if this lady is obese.
And that's a good point that you raised about investigating for other systemic events. Now, one thing that I would like to ask the panel is, I mean, how often do you use spironolactone? Do you prefer eplerenone or spironolactone, or I mean, does it really make a difference? Because in terms of potassium hyperkalemia, these have similar effects. Do you have a preference over either of these, Dr. Abhishek?
I use eplerenone when I really when the patient is running out of options. Especially nowadays, if you have a subfoveal leak or a juxtafoveal leak and PDT is not available, that is when I use it. I have not had too much success with eplerenone, and I mean it's not something that I look forward to using as a primary method. It's mostly when you're in a corner, when other options are not available, that is the time I use it. If sometimes you have very thin fluid in a chronic CSR, fluid is there, but it's very thin, and the leak is either very close to the fovea, or sometimes the area of fluid is so less that you wouldn't be planning a laser. That is where I would use it. But I used spironolactone for a very few patients initially. Then I switched over to eplerenone because side effect profile is better, it's safer. So that's the reason that you don't want to start another trouble for the patient. He already has one.
Dr. Darais?
Yeah, I agree with Abhishek, because the safety profile is better with eplerenone. It's readily available. One thing we have to remember is in the US, I think eplerenone is prohibitively more expensive than spironolactone. So even if you read the articles which are published, which there's a control study between the two, the justification they give in that article is because of the cost, because of being a proprietary drug. So since we don't have this problem in India, I would definitely prefer eplerenone. And definitely because we don't have PDT, this is something which I'm started using a lot. Earlier, we would not really think too much about it and try to encourage patients for PDT. But it has worked in some patients. And one interesting subset is patients who are hypertensive. I just make a note for the physician and say that please switch the antihypertensive to eplerenone and stop whatever else if it's safe, whatever for the patient. And I think some of them have done well. So again, no published data, but I think it's a good option, especially when we are running out of options.
Yeah, that's a very important point that you said, because I also had a patient where I started the patient on spironolactone. And this patient ended up with a severe hypotension because he's already on an antihypertensive. I don't know, he took some time to see his physician. So these people have to go back to their physicians and get their electrolytes monitored, and that's an important thing that you raised. We'll just take one last question. I mean, this is somebody sent me this question. So the question is, when do you decide to do an early FA or an ICG? Do you really look at biomarker clues and then decide, okay, this is a patient when I would do an early FA ICG? Dr. Prakash?
Yeah, exactly. If it is an atypical case, I would go ahead for an early FA ICG. If it's a typical CSR, I won't go for an early FA or ICG. I wait to look for spontaneous resolution of the disease.
Okay. Dr. Abhishek, any biomarker clues that you would base it on?
Yeah, so like I said earlier, if your choroid is looking the way it did in this case, if there is an indication of a pachychoroid or an irregular, choroid underlying the CSR, or if there's a lot of exudation in the retina, then definitely I would go for an ICG earlier on.
Yeah, we are also, in this particular case, we are also thinking of a type 3 UL deficient syndrome, because sometimes you can have similar features. I think we've had a very interesting case discussion. I'd like to thank the presenters and the panel for all the contributions. I would like to request Dr. Uni to take over for the rest of the session. Thank you.
Thank you all.
Thank you, Dr. Manoj.
Yeah, good evening, everybody, and thank you, Dr. Manoj, for chairing that session seamlessly. So we're just starting with the UVA session, and first Let me get the slides up. Okay. So I'd like to first introduce a very close friend of mine, Dr. Sudarshan. As you can see, he's a very charming personality and a very popular person in Shankara Nethralaya. He's a senior consultant in the Department of Uvea, and he has got keen areas of interest in uveitis, ocular diseases of immunosuppression. Cataracts. Is a good, but really accomplished cataract surgeon, and pediatric uveitis, and has got many publications in national and international journals. He's an investigator in many clinical trials. But what most defines him well, he's a wonderful PG teacher and mentor of fellows, and is a very popular figure on the Shankara Nethralaya campus. He's also the assistant editor in the Uvea section of the IG and the USI treasurer. I'd like to introduce our panelist, the extremely dashing personality, Dr. Natasha Radhakrishnan, a very close colleague. We were overlapping during our masters at the RII Trivandrum. Dr. Natasha is an All India gold medalist in DNB, has special interest in pediatric retina, especially ROP and uvea. Dr. Natasha is a very eminent speaker, speaking about ROP and uvea, and has trained quite a lot of fellows in retina at the Amrita Institute. I'd like to introduce our own faculty who will be doing the presentations. Dr. Nivedita Nair, consultant in uvea and ocular immunology. Dr. Sri Lekha, who is a consultant in retina, and Dr. Vandana Pradeep, who is a consultant in our sister concern in Kollam in uvea and ocular immunology. So with this, first, I would like to hand over the proceedings for the first case to Dr. Nivedita, who will present the first patient, first case. Dr. Nivedita. Can you unmute, please, Dr. Nivedita? Dr. Nivedita, can you unmute,
Yes,
please?
yes.
Yeah.
Today I'll be presenting a curious case of a 78-year-old gentleman who had presented with sequential vision loss in the left eye, 20 days duration, followed by the right eye, vision loss since 4 days. He had associated headache, pain, and redness in both eyes. He was admitted at the neurology department and was referred for ocular evaluation. There was history of hypertension, vitiligo for 20 years, and he was a hypothyroid. On examination, best corrected vision was 612 N10 in right eye and 618 N12 in left eye. There was granulomatous uveitis with mutton fat KPs, AC reaction of 2+, Busaka nodules in the iris, posterior synechiae, and NS2 to 3 cataract. Fundus view was very hazy due to the cataract and vitreous inflammation, but we could make out a bilateral disc edema. There was no obvious choroidal lesions, patches, vasculitis, and no obvious exudative detachment. An OCT through the disc showed gross disc edema in both eyes. Macular OCT was, however, normal. There was no subretinal fluid, and on B scan there was normal RCS thickening. No mass lesions or CD choroidal detachment or retinal detachment was noted. Since he was referred from the neurology unit, he had already obtained an MRI brain, which showed a likely pachymeningitis feature, and a CSF study was also done, which showed pleocytosis. We ordered for other uveitis workup, Manto, HRCT, except for a hilar lymph node, it was normal. Pulmonary fields were normal, and serum ACE level was within normal limit. So, considering the bilateral granulomatous panuveitis in this patient with features of pachymeningitis, CSF pleocytosis, and also long-standing vitiligo, we considered the possibility of a weak age disease. Since it was granulomatous uveitis, we considered TB sarcoid, and considering his advanced stage, he was 78-year-old. So we also considered the possibility of masquerades. With concurrence from the neurologist, he was initiated on IVMP 1 gram 5 days for 5 days with tapering oral steroids, and he had a good response to treatment. He reviewed with us three post IVMP and on oral steroids of 30 milligram. We saw that the vitreous inflammation was subsiding and the disc edema was also reduced. The anterior segment had fully quietened down by this time. So he was on monthly review for 2 months and he was doing well. Oral steroids were advised to be tapered slowly. Vision had improved to 612 in both eyes. Although he remained on follow-up with the neurologist, he didn't follow up with us for 3 months. Then the next presentation was 6 months from the first visit. He had no other ocular problems at this time, ocular complaints as such. Best corrected vision was 6.9 and 8 in the right eye, and left eye was 6.9 and 8. There was no anterior segment inflammation or anterior vitreous inflammation. But on fundus image, we saw these curious peculiar lesions in the peripapillary area, yellow-white lesions in the peripapillary area. On further imaging, in IR and multicolor image showed these lesions, suggesting a lesion at the level of RP and on in both eyes. And on autofluorescence, it was showing a hypoautofluorescent lesion with a hyper-autofluorescent edge. It could be an inflammatory deposit or lipofuscin. The FFA and ICG at this stage, the early mid phase of the angiogram, there was a hyperfluorescent lesion which was increasing in number and size during in the late phase, and the disc was also leaky. On ICG, however, we saw these hypofluorescent lesions around the disc and also at the level in the arcade, but which became ISO in the late phase, but the lesions around the disc were densely hyposinucent in the late phases, which were much more than what we could pick clinically. And OCT, it showed these peculiar knob-shaped sub-RP lesions in both eyes around the disc. So our differentials at this stage for the sub-RP deposits, infiltrative pathology like ocular lymphoma, leukemia, or metastasis was considered. Although TB and sarcoid was in our diagnosis, in our differentials. Generalized systemic workup was again advised. We did all tumor markers like CEA, CA125, PSA, all came out negative. PET scan was ordered. There was multiple hilar lymph nodes from which a bronchoscopy guided biopsy was done, and granulomas were noted, which was consistent with diagnosis of sarcoidosis. So immunologist was consulted and he was started on mycophenolate mofetil 2 grams per day. So this is the EDI OCT 3 months post MMF. We can see that the sub-RP deposits have flattened. His vision is maintained at 6.9 and he is awaiting cataract surgery now. Thank you.
Thank you, Dr. Nivedita. That was, it is an interesting patient. So we're going to throw open the discussion now. First, I'd like to start with Dr. Sudarshan. Hi, Sudarshan, how are you?
Hi.
So the thing is that in this patient, the most, let's say that we have two features initially, one of disc edema and one feature of subretinal yellowish deposits. Which of these strikes more concern in you first?
Initially, definitely the disc edema, because like if at all the patient is going to lose vision fast, it's going to be because of the disc edema rather than the sub-RP deposits. So like considering that inflammatory signs are also present initially, so probably the initial, at least for the treatment part of it, on an emergency basis, probably I'll start looking at the disc edema and the panuveitis part first.
Okay. So the next, say, when you see a disc edema with this some sort of inflammatory component, how strongly would you have suspected VKH as the first diagnosis in this patient, Dr. Natasha?
Hi, Unni. Thank you for this opportunity. Am I audible?
Yes.
Yeah. Yes. I was just thinking of that myself. Bilateral granulomatous panuveitis with just disc edema. And the view is not really visible for anything further to be done. Like I was asking Nivedita, I think the FFA was not done at that time, isn't it?
Yes, ma'am. The view was very hazy.
Yeah, a little bit more view, and the fluorescent angiogram would have given us more information.
For the angiogram once the IVMP was done, but then they came back a few weeks later. By that time, it had all resolved.
Yeah, but then the things that would like I would be looking for is choroidal thickening on ultrasound when I can't get a view, and that would point more in favor of VKH. The vitiligo history doesn't seem to be significant here because that is 20 years and that is just autoimmune vitiligo, not related to what the uveitis that he got, because in VKH the vitiligo comes usually after the uveitis. So that would not be a pointer. And here choroidal thickening was absent. It was normal. Another thing, of course, in favor would be the pleocytosis and a little bit of pachymeningitis that we got on the neurology evaluation. So like Dr. Sudarshan said, we would go ahead with the IVMP. That would probably be the best way to do it. But VKH itself is definitely not up there on the list in this patient. Maybe other causes of granulomatous panuveitis, especially with those few hilar lymph nodes that we picked up on the CT, maybe we should have delved a little bit more. Maybe it was in evolution then and we wouldn't have got anything much in the EBUS, but we could have investigated a little bit more in that direction.
Yeah, I think the sequence probably will be like sarcoid, TB, masquerade, and then VKH, if at all.
Yes, that's
that
right.
will be the
That's
order,
my thought
maybe.
process too. Yes.
So, Dr. Sudarshan, how would you deviate in your, let's say, not the management, but from the evaluation perspective?
Management also probably, like if at all I'm depends on that particular day. Like if I'm too bold, probably I would have started off IVMP in a patient where I can't see the fundus very well. But otherwise, in a granulomatous uveitis, somebody who's complaining of pain where you cannot see the retina fully in a 78-year-old, then probably oral steroids a week or two also would have cleared the vitreous better, and then you could have done the FFA. But then IVMP, retrospectively speaking, then IVMP was a good option, and you've actually cleared. So IVMP sometimes I'm a little scary if I'm a little scared if I can't see the fundus well. There are few things that's like see any exudative RD or an SRF pocket has to be there for VKH actually. So otherwise, like it doesn't go in. A patient, a 78-year-old with a MAN2 negativity, then either he's an immunocompromised one or he's sarcoid. Okay, unless it is probably like if it's not improving, then maybe I would have gone ahead with a vitreous biopsy or something like that straight away.
Okay, Dr. Natasha, how often do you hit a diagnosis when you have a patient like this with subretinal deposits and choroidal? Because I know that in AIMS you have wonderful facilities to go all the way if you want to, but how often do you hit a diagnosis in these patients?
Yeah, I think there's you are talking about the second presentation, isn't it? When it came back 6 months later. Yeah, I think that the pointer that gives me an idea that there is something deeper going on is the development of those RPE changes. If you would have seen, you can see much more of those changes in the ICG than it was there clinically and in the FFA. That is showing some kind of widespread RPE disease. And after a couple of mishaps, like bad diagnosis, I tend to be very wary about seeing these RPE changes. If I see RPE changes that are not explainable by the primary disease the patient had, I will be thinking in terms of lymphomas and paraneoplastic syndromes first. Because because that is especially in this age group. And I would have gone all out, like you said, PET scan and the thing to find out if there is something else going on. I've had a couple of patients whom we have mistaken for VKH because they had exudative RD also to begin with, but ended up having paraneoplastic syndrome due to metastatic breast CA and all that. So that is a good pointer. And yes, we would go for endobronchial sampling for tissue biopsy if there are hilar lymph nodes, and PET scans, like you said, all out to get a diagnosis.
Dr. Sudarshan, I was just asking, from a clinical perspective, what are the pearls you can give for a clinician to differentiate between an inflammatory and an infiltrative pathology in a patient who has a panuveitic syndrome with sub-RP deposits?
Sub-RP deposits coming in acute phase, I don't see it that often straight away. Like if in case, most of the time it comes in the later stage or in the resolving stage. But any patient beyond 60, 65, if it is any of the inflammatory thing, the first thing higher up in the diagnosis list is definitely a masquerade, either a primary malignancy or lymphoma or a metastatic, as Natasha was telling. Interestingly, there was one, I was just trying to read an article related to this when they were discussing about it. There was somebody's written a letter somewhere to an editor where sarcoid comes first and then it's followed by lymphoma in a patient, in an elderly patient who can present like this. So they say like initial presentation can have a biopsy proven sarcoid, which can be followed by an NHL. So if at all you are following up this patient, probably this is like one which seems to be following the similar course. But otherwise, anybody in the 15 to 45 or 50-year age group coming with the granulomatous panuveitis, then like a masquerade or a lymphoma comes much more lower in the list.
Dr. Natasha, any clinical tips that would point to for you to say that you, besides the age and the type of the chronicity and the acuteness of, is there any other clinical tips that you would look for to differentiate between infiltrative and inflammatory?
I think the signs of inflammation, of course, infiltrative, though the vitreous haze will be there, we would not expect so much of pain, redness, the typical uveitis presentation. That is kind of pointing in favor of inflammatory rather than infiltrative. The infiltrative, they may have a vitreous haze, they may have an exudative RD, they may have the RP changes and the RP deposits, but the actual anterior segment signs of inflammation may not be so much. That would be one pointer. The other probably in the, again, like I said, the RP changes are again, they don't usually happen in our inflammatory conditions. If I see some kind of choroiditis lesions, like when in the initial stage of the inflammation, then I would probably look for, the distribution, which is like all the TB experts are always saying, along the vessels. If the choroiditis lesions are distributed along the vessels, you are looking at tuberculosis. And of course, then the perivasculitis, any evidence. In this patient, all that is difficult because the view was so hazy. But in a other patient who has a little more dilated pupil, you will be able to see any lesions in the periphery. It's a complete retinal examination will probably give us the first clue whether we are looking at inflammatory or infiltrative.
Okay. So can you just end with two quick questions? One, Dr. Sudarshan, the role of biopsies. How often do you use biopsies? The different types of biopsies in patients like these, vitreous and retinal biopsies, subretinal biopsies.
I mean, Esther, like we are relatively conservative otherwise, but retinal biopsy is not so often. But vitreous biopsies, yes, like at least if at all there are some pointers suggestive of some inflammatory, then initially it's always a course of steroids or maybe if there is recurrence and immunomodulator initially, if CNS imaging is not proven to be anything suggestive. In this, like if MRI is not showing anything positive, then probably we'll try a course of anti-inflammatory therapy. But if otherwise, if there is a strong suspicion not fitting into, in this patient, if at all they had only vitritis without granulomatous KPs or anything, then probably we would have been going ahead straight away with the vitreous biopsy.
So I think we've covered a significant amount regarding that case. We'll probably talk a little bit more about it when we come to the algorithm. Okay, so now I think we're time up for the case, and now we'll listen to Dr. Sudarshan talking about pattern recognition, which kind of sums up quite a lot of important things, even regarding this case. So Dr. Sudarshan, over to you for your keynote on pattern recognition in uveitis.
Thanks, Oni and the whole team. It's nice to be there on a Sunday evening. Actually, I'm at home. So I was probably giving a stressful time to Nivedita, whether I'll reach in time to my native place. And I think every time I was just discussing with Natasha that every time there is a conference or uveitis related CME in Kerala, I seem to be traveling to my parents' place. So anyway, without wasting too much of time, this was something hot in the WhatsApp just now, like evening I saw this forward. So this is what I think we most of us keep doing actually. So you keep talking and hoping and imagining that like there are 100 people listening to us, then I don't know, like rather than being very delusional, let me go off to this straight away. Pattern, like we keep talking about pattern and appearance. So when you see something like this, like what comes to your mind? Like that's what, so each of us may be thinking different things based on whom we like or whom we don't like. So no politics actually. So so the next thing what you do is you start looking for any supportive pattern or evidence. So you see if there is any other subtle features like somebody, their headgear, their specs or their other features, and depends on what they talk. Whether they talk literary, they talk hyper-nationalism, spiritualism, atheism, or rationalism. So investigate and try to confirm. So is it in uveitis? Something like this for a Kerala special, like this song seems to be coming in my mind quite often. So when you see something like this, you start humming this song, and when you see this picture, you start humming another song. So this is how what it is. Like you observe, associate something with a memory because you've seen it in the past or somebody's told you about it, and support the claim. Few things like this, you know whose smile these are. Like I don't need to be telling you guys. Or something very hot nowadays, some hyper national, you don't know which language this belongs to, then you know that you are looking at somebody. So sometimes it is very straight away clinching, sometimes it is hinting. So that is what it is in uveitis also. Uveitis is like dermatology, you know? Like you look at the spotter and then you start looking for history again. So I'll just try to show a few examples where you can diagnose with slit lamp alone, or slit lamp and indirect alone, or with some basic lab and ancillary investigation. Try to identify the pattern and diagnose the uveitic entity. And basically you'll have to spot the pattern, identify and match it to the known patterns. Like the known patterns are defined very well in the literature, or like somebody's taught you or you would have seen before. Look for supportive evidence. If it is not typically fitting into any of the patterns, you can have some subtle systemic or subtle ocular features, try to match it. And based on that, go ahead with, and investigate. Sometimes you don't need to have a battery of investigation. Based on these features, you can go priority-wise investigate and confirm the diagnosis. Patterns actually make you lean towards an etiology. So priority-wise, and that is how it will be the differential diagnosis. So a few characteristic anterior patterns. So there are 3 or 4 major anterior uveitic patterns. So either it's a fibrin or an organized coagulum or a hypopyon, or a granulomatous uveitis group, a scattered KPs. Let's look at each of them and look for posterior segment clues or indicators when these are present. So, for example, this one is a typical characteristic organized coagulum or a fibrin. So this picture probably most of you have seen quite a lot. This is like a characteristic sunken SN picture going around everywhere. This is probably relatively new. Fibrin organized coagulum in a young adult. You don't need to think too much about it. It's a very characteristic of a HLA-B27 associated uveitis. So any young adult coming with an organized coagulum, fibrin, especially unilateral, or if it is alternating, then you straight away ask for history of backache or a skin lesion. Then you're dealing probably with the case of a HLA-B27 associated uveitis and treat it. But if it's a hypopyon, then you need to be little more wary. Your antennas need to be up. Then you start looking at the characteristics of the hypopyon, look at the history and ocular systemic signs and symptoms, look at the glow. See, look at the characteristic of the hypopyon. If it's a transient mobile hypopyon, then it will be so transient that you make the patient lie down in for indirect and the patient make the patient get up, then it actually clears up. So that kind of hypopyon, and if it has a posterior uveitic vasculitic features or an aphthous ulcer, then you're probably dealing with Behçet's. Or if it's on the other hand, if it's a convex or a thick hypopyon, then probably you're dealing with an infective one. Look at this glow. A yellow glow like this means there is an infective etiology, infective disease phenomenon happening and behind. So it can be a infective one like a viral, or it can be an endophthalmitis. Any hypopyon, rule out infection first, then uveitis. So a fibrin or organized coagulum can be HLA-B27, but a hypopyon can be Behçet's or infective or masquerade. A granulomatous uveitis. This is an active granulomatous uveitis. You have the broad-based NAK, you have the iris nodules. A granulomatous uveitis straight away doesn't give you any diagnosis. But the top two DD in India, at least, especially is like TB and sarcoid. You have the whole spectrum of other diseases which can present with granulomatous uveitis. So you look for posterior segment clues and indicators when you have a granulomatous uveitis. Most granulomatous uveitis can have some kind of posterior segment clue or indicator. As we were just discussing, TB, like the TB bosses like Natasha was mentioning, they say about a choroidal granuloma or a subretinal abscess or a serpiginous like choroiditis or a occlusive vasculitis. So these things are phenotypically ocular TB. So if you have any of this, then you can lean more towards TB. But not always do you get active posterior segment lesion. So you need to actually, you might sometimes get a heel lesion. CRA adjacent to a vessel, even if it is there's no active posterior uveitis and a granulomatous anterior uveitis like this, you probably lean towards ocular TB. So you have described ocular TB features phenotypically, which you need to weigh it more towards ocular TB and which you needn't. But if the posterior segment has these skip lesions or candle wax drippings or pre-retinal granulomata, then you know you're not, probably you're leaning more towards sarcoid. And along with that, if you have a granulomatous uveitis which has angular capes or a conjunctival nodule, then you are leaning more towards sarcoid. So uveitis is all about how much each of the sign and symptom, how much you can reason it out and how much you have to weigh each of them. So granulomatous uveitis can be TB, sarcoid, it can be anything else. Another interesting thing about the anterior uveitis is the scattered capes. So a scattered KP is something that's kind of a spotter in every thing. We many times when I walk across and I find a young adult with one eye uveitis, I keep showing off to my fellows that see, this is Fuchs. So most of the time the scattered KPs come with unilateral cataract, or it can have some pigmented ones. The two main differential diagnoses are either Fuchs or viral. A scattered KP without any pigmentation, or if there is a pigmentation with sectoral iris atrophy, then you're probably dealing with viral. Look for corneal sensations which may be absent. A raised IOP with this is definitely viral. The nearest differential diagnosis is Postner-Schlossman syndrome. There are other spotters. You don't need to do a battery of investigations for this. This is herpes zoster ophthalmicus, this is cysticercus. And if you find anything like this in a young child, then it is juvenile idiopathic arthritis. So you have some 3-4 specific patterns in anterior, and the rest of it, obviously, if it is not fitting, then you need to investigate. So it's about minimum, not governance, in investigations and maximal treatment. So we saw anterior patterns. Now let's see a few posterior patterns. Posteriorly, anything yellow in the fundus is very exciting. Probably like HIV, uveitis, and maybe a little bit of diabetic are the three things where you find a lot of interesting things in the fundus. So you have a retinitis, choroiditis, or retinochoroiditis. The key thing is the retinal blood vessel and its relation to the lesion. If the retinal blood vessel is seen or not seen, based on that you decide whether it's a retinitis, retinochoroiditis, or a choroiditis. But nowadays you have the OCT and other imaging techniques which can decide the inflammatory level. So why is it so important? Because whenever retina is involved, a retinitis or a retinochoroiditis, it's almost always infectious. It can be viral, toxo, syphilis, and so many others. But always remember that a retinitis or retinochoroiditis cannot be non-infective. Behçet's is something where you can have retinitis-like lesion, which is the only non-infective condition where you find a retinal involvement. But otherwise, it is always infective. Choroiditis can be infective or non-infective. Any retinitis, choroiditis, or retinochoroiditis, you need to look at the location, number, shape, and all these associated features. Let's come to each of them. So for example, this is one. If you have a focal lesion like this, then you go through all these. Look at the location, look at the number, what is the shape, and what are the associated features. This is a central focal retinochoroiditis, has a local vitreous haze. There are some fluids, see the ileum folds. And if you ask for history of contact with pets, if it is supportive, then you know that it matches with the known pattern, then it's a headlight in the fog appearance, which is a toxoplasmosis. So you always describe the lesion, see if it matches with any of the known patterns, see if there is any supportive history, then you know the diagnosis. But the same focal, if it is there in the periphery, then it is not toxo. Then you're probably dealing with something else. So this is something not very common, you see, but it's good to remember that if you have a multifocal retinitis all around in the periphery, then it's probably viral. This can be an early stage of an ARN. But if the same peripheral ones are coalesced and extensive, see if there is anything else associated. See the picture. It's like very hazy. It means that there is a lot of vitritis and vitreous haze. These are peripheral coalescing lesions. And look close, they are scalloped margins. So we know that this matches with a known pattern, which is seen in acute retinal necrosis. So a peripheral coalescing necrotizing retinitis, moderate to severe vitritis, along with the vessel involvement, we know that it is acute retinal necrosis. But when the same retinitis, if it is involving the posterior pole and very diffuse and all over the fundus, then you know you'll have to again start looking at the pattern. This is a very clear fundus picture. It means that the vitreous haze is hardly there anything. Then if there is a very clear view of the fundus, then you always see if the patient is immunocompromised, because the inflammatory response is very poor. And in this patient, we know that this is a cracked mud appearance, and this is usually seen in HIV/AIDS, and that is why the vitreous haze is not there. This is a case of a progressive outer retinal necrosis. So talking of HIV can be as characteristic as it can get and as atypical. It can have very characteristic features like a cracked mud appearance, or it can have a diffuse extensive retinitis like this. See, this doesn't fit into anything. So HIV can be so typical or so atypical. This is actually atypical toxo. The only way you can differentiate this is the absence or hardly any hemorrhages in these. Whereas in a viral retinitis, it can have a lot of hemorrhages, because this is the characteristic picture which we have always been taught about: a diffuse retinitis with along the vessels, like a brush fire pattern. A pizza pie appearance is the matching pattern which we know. This is a hemorrhagic type of CMV. But always remember that CMV need not necessarily be hemorrhagic. They can have a granular one. In a HIV patient, if you have a granular powdery type of appearance of a retinitis, then you're dealing with another type of CMV retinitis. Talking of retinitis and hemorrhages, if you have these scattered hemorrhages and retinitis-like lesions and retinal whitening everywhere with ischemic points, ask for history of fever, then you are dealing with the whole spectrum of epidemic retinitis or post-fever retinitis. Of course, now with COVID can present with anything. So we saw retinitis, choroiditis also. You can go through the same thing. We are just discussing about TB and sarcoid. A solitary choroidal nodule can be usually TB or sarcoid. It is not very clinically significant or a p-value significant, but I keep telling that if it is more orangish, it means it's much more deeper layers are involved. That's how OCT they try to differentiate between TB and sarcoid. The satellite layer is enlarged in sarcoid, while in TB the contact sign is seen. It means that it is very subretinal. A more subretinal lesion is more yellowish. A more deeper lesion is more orangish. We have the whole spectrum of white dot syndromes, but let's see the common ones. Multiple choroidal lesions come under the multifocal choroiditis. If you have the placoid choroidal lesions all around, which are very discrete, then you're probably dealing with APMPP. But the same placoid lesions, if they coalesce and form a snake-like pattern in few places and not coalescing at a few places. So these are all separate. Here it's like coalescing at some point, and some points it's not coalescing, then this is amphigenous. If it is coalescing everywhere and it's starting from the disc in a classical pattern, this is the classical GHPC or classical serpiginous, which is usually autoimmune. But the same one, if it is in the mid-periphery along with vitritis or vasculitis, then it is a serpiginous-like. And nowadays we keep telling that it is very pathognomonic or phenotypically strongly tuberculous. We saw all these typical lesions. What if it's a bit atypical like this? This doesn't seem to be a diffuse retinitis or a granuloma or a retinochoroiditis. It's not focal, that focal. So you look, see if there are any other supportive evidence. This is the Chiariles arteriolitis. a vessel like this with a vitreous haze or a retinochoroidal lesion, then it means that it's probably toxoplasmosis. So this is how it is. Toxoplasmosis can have multiple lesions in immunocompromised. It can have a focal retinitis. It can have a lesion adjacent to a scar, but it can also have an aqueous toxo with an overlying vitritis, which is atypical, and a chirales arteriolitis. So not always do we get very typical lesions, but you can get atypical lesions. But you should look for the subtle supportive evidence. When you're talking about atypical lesions, I don't know whether these grammatically, if I'm right, the characteristic atypical presentations are usually seen in syphilis. So syphilis, anything atypical, think of syphilis. In syphilis, if you have a salt pepper retinopathy, rather, if you have a salt pepper retinopathy or precipitates at the posterior hyaloid phase like this, or a diffuse retinitis with placoid chorioretinitis, then you're probably dealing with syphilis. Do RPR TPHA. Syphilis is a diagnosis by exclusion. And if you have a suggestive history, especially with the current group of MSMs, then you're probably dealing with syphilis. If it's atypical, doesn't seem to fit in anything, doesn't have any supportive evidence, then intraocular specimen evaluation, PCR for diagnosis is the ultimate choice. Sometimes even the resolution pattern can be diagnostic. This is CMV, all of us know. See the way it resolves. CMV resolves from center to periphery. The periphery resolves last, while in toxo, it resolves from periphery to center. The center one resolves last. So resolution pattern also sometimes can give a diagnosis of the organism. The last pattern, coming away from retinitis or choroiditis, we are talking about disc edema and hyperemia and SRF. In our patient, we didn't have the SRF, but later on we started getting the RP deposits. This is a bilateral disc edema and hyperemia. These are the subretinal fluid pockets. If you have a bilateral disc edema with hyperemia, the first differential diagnosis is VKH if there is SRF pockets. Then you look for whether it's a granulomatous one or a bilateral one. Always remember that FFA is a must in these patients because the moment the view gets better, you do FFA to confirm the diagnosis. Ultrasound rundosity can also help in the diagnosis. Ultrasound can give the choroidal thickness, or in posterior scleritis, it can give the T sign. Look for the other eye, whether there is an injury or not, to rule out sympathetic ophthalmia. This is the typical starry sky pattern. So we have patterns in uveitis even in FFA. A starry sky pattern is typical of VKH or sympathetic ophthalmia. You can also see in posterior scleritis. And SRF pockets, if it is unilateral with inflammatory signs, it can be early Haradas. But if without inflammatory signs, you always rule out multifocal CSR. This is a subretinal fluid fibrin. We have had enough discussion on CSR just now. But just to complete, if there is a clearing in the middle, then clinically you can make out that it's probably CSR, not VKH or a choroiditis. Remember that you need to always remember that diseases don't always follow textbooks. Patterns are easy to diagnose, but not always is it confirmatory. Sometimes you need to be aware of imitations, pseudo-uveitis or masquerade. In Tamil, they say, Kannal kanbadu poi, kadal ketpadu poi, thire visaripade mei. I tried to get the Malayalam equivalent, but I couldn't get it in any case. So to conclude, you spot the pattern, identify and match it with known patterns, look for supporting evidence, investigate and confirm. So whatever it is, the parting shot is like whichever model it is, one thing you remember, like God, I don't know whether it's present, but COVID is ultimately omnipresent. Stay safe. Hope it doesn't come to a stage like this even at home. Thanks once again, Nuni, Minu, Nivedita, and the whole Synoptic team.
Thank you, Sudarshan, for that. His usual wonderful talks with that, talking about typical patterns, atypical pearls, and subtle hidden political satire, which is pushed in between. Okay, anyway, it's all good fun. So I'd like to thank Natasha for her wonderful participation in the panel discussion also. I request both of you to stay on for some more time. We'll have the consensus algorithms now. First, the retinal algorithm, followed by the UV algorithm. So now to Dr. Srilekha, please, for her presentation of the algorithm of the two retinal cases. Dr. Srilekha.
Yes. Good evening, all. Okay, now from the recently concluded discussions, we have been able to arrive at consensus algorithm for the two commonly encountered disease entities, that is diabetic macular edema and central serous chorioretinopathy. So first we'll be coming to the algorithm for diabetic macular edema. DME can be classified based on OCT into tractional and non-tractional varieties. So in tractional variety, when there is evidence of epiretinal membrane, significant membrane or vitreomacular traction, there is no doubt as to the management being surgical, that is vitrectomy. So now coming to the non-tractional varieties, whether be it central thickness, spongy diffuse thickening, cystoid macular edema, submacular detachment, whatever, these can be classified into center involving macular edema or non-center involving macular edema based on whether the thickness or edema is within or outside 100 micrometer of the fovea. So for non-central edema, again, we will go for focal laser. And if the edema is more, we may consider addition of anti-VEGF. And coming to the center involving macular edema, we can go ahead with predominantly first-line anti-VEGF treatment. And in certain situations, even also DEX that we will come into later. So coming to anti-VEGF treatment, we give anti-VEGF, monthly anti-VEGF injections and monitor with OCT, and we monitor the response after 3 injections. We can again categorize these into adequate response, inadequate response, and no response. Adequate response is when the visual acuity has improved and the central macular thickness is less than 300 microns, or an improvement in the CMT of more than 10% from baseline. Here we can continue with our anti-VEGF therapy. And once the vision reaches 6/6 or CMT is less than 300 microns, we can observe. If there is no change in vision or OCT after 2 consecutive injections on follow-up, we can consider treat and extend. And in situation where stability is achieved, there is no worsening of vision or there is no further improvement in macular edema, we can consider defer and extend. That is, we can extend our follow-up period to further 3 to 4 monthly. So now coming to the second group, that is the inadequate response. Here, the visual acuity improved or stable, and the central macular thickness is still remaining more than 300 microns. Or change in CMT is less than 10% from baseline. Here we can persist with the anti-VEGF therapy, or we can switch to another anti-VEGF or switch to steroids. When there is no response, that is, vision is remaining the same, and the central macular thickness is more than 300 microns, and the CMT is less than 10% from baseline, then we have the option of switching to steroids. So once we switch to steroids, we prefer basically intravitreal dexamethasone implant, that is also DEX. We will evaluate with the IOP measurements and check for cataract development and assess with OCT after 3 months. Again, we can categorize into inadequate or no response or adequate response. Once we get an adequate response, we can again continue with Osodex every 4 to 6 months. When there's inadequate response, then we can switch to anti-VEGF if we have started out with Osodex primarily. So whatever be the situation, whether we switch to anti-VEGF or steroids, just before switching, we can reassess our status of macula by doing angiography, better fluorescein angiography, or even OCT angiography to rule out macular ischemia, which may be the reason for the poor response. At this stage, we can consider adding focal laser as we have already discussed during this discussion about treating retinocapillary macroaneurysms. So coming to special situations, if there is a PDR, we'll definitely go for PRP laser. Macular edema, in such cases, we prefer to have treatment with anti-VEGF over steroids. So anti-VEGF, we have already discussed, is preferred by most as first-line treatment, and especially in phakic patients and glaucoma eyes. But Ozurdex may be preferred as first-line in certain situations in patients with a high risk of thromboembolism, for patients with a poor compliance, chronicity on OCT that we have discussed regarding cystic degeneration, hard exudates, septae formation. In pseudophakic patients, but we prefer to avoid in aphakia. And when there is a history of previous vitrectomy, because it is known that in vitrectomized eyes, the anti-VEGF is cleared much faster, so the effect will be less. Finally, as alternative to Ozurdex, we may consider intravitreal triamcinolone acetonide, but it has more side effects in terms of IOP rise and cataract formation. So that will be our algorithm on diabetic macular edema. Can we move on to the next part?
Yes, we can, I think, yeah.
Okay, so now we'll come into the second part, that is central serous chorioretinopathy. After wading in so much of fluid, I think we have finally arrived at a consensus algorithm that will definitely shows the shoreline. So when categorizing the disease, the duration of the disease is really important. So with a history of less than 3 to 6 months, we classify it as acute CSER, and anything beyond that, we can categorize it into chronic or atypical cases and other cases. So further classification is based upon the findings in fundus examination, OCT findings, either EDI, that is enhanced depth imaging OCT or sepsis OCT, as well as wide field fundus autofluorescence. So in acute CSER, the fundus examination shows macular fluid without any pigmentary changes. And the OCT shows pachychoroid, subretinal fluid, and serous PEDs without any significant autofluorescence. Whereas in chronic cases, the fundus examination shows additional pigmentary changes in addition to the fluid. And OCT also shows other changes such as flat irregular PEDs, and there will be abnormal AF patches or tracks. Then we call it as chronic CSER. And in atypical CSER, we have other features coming in, that is age as such more than 50 years, bullous SRF, especially bilateral cases, and OCT in addition showing intraretinal exudation, the cystoid macular edema and skytic changes, and intraretinal fluid out of proportion to the subretinal fluid component, and other features such as fibrovascular PEDs, and wide field autofluorescence showing abnormal AF patches. Then we can categorize this as atypical CSER. And when the changes are predominantly in the peripapillary area with a small nasal pachyvessels and nasal schisis, then we can categorize it as peripapillary pachychoroid syndrome. Now coming to the acute CSER, in majority of cases, we prefer to observe only, and it is resolved without any active management. But in cases where it is not resolving over this period of 3 to 6 months, or there is a progressive vision drop or abnormal OCT findings such as subretinal hyperreflective material, then we would suggest going in for a combined angiography, that is fluorescein and ICG angiography. So this will definitely detect some pattern of leak, either focal leaks in plot or smokestack leak, or even multiple leaks, and the ICG showing choroidal hyperpermeability. And depending upon the location of leaks, When the leaks are predominantly extrafoveal, we can deal with the focal laser. Whereas when the leaks are predominantly subfoveal and juxtafoveal, then we would prefer reduced fluence PDT or micropulse or oral eplerenone. So that is about the acute CSCR. Now coming to all other categories, whether chronic, atypical CSCR, then we would prefer a combined angiography at the onset itself. So the FA and ICG will detect focal leaks or diffuse staining, or in certain cases, focal hypercynoscence. In whatever be the pattern, the next thing would be to categorize with OCT angiography to detect a network, whether there is a network or not. So when we detect a network, then there is a no doubt as to we have to go for anti-VEGF therapy. Whereas when there is no network, again, for extrafoveal disease, we would prefer focal laser. And for foveal and subfoveal disease, we can go in for PDT, micropulse, or eplerenone. So I think that has bring in some clarification about our management protocol in these two categories. Thank you very much.
Thank you so much, Dr. Srilekha. Just like to mention 2 points. One regarding a generalized idea about DME management. It's a very simple, nice concept. If the patient is improving, it's counterintuitive. If the patient is improving, you continue. If the patient is worsening, you have to think of alternatives. But the point comes when the patient fails to improve or fails to worsen further. That is when the issue about stopping treatment. It's a new concept that none of us even believe in. That is whether to stop anti-VEGF. So that's a very interesting point in DME management nowadays based on studies. Now coming to CSR, I'd like to make two small points from the algorithm. One is one of the most important tests is the autofluorescence. Rather than anything else, the autofluorescence will tell you what is going to be your success with focal treatment. If it is a very focal disease based on the autofluorescence features, you may get away with an intensively focal treatment. But if the autofluorescence shows a large area of involvement, you are likely to have recurrences again, and the disease will continue despite treatment. Similarly, to the autofluorescence is a role of identifying choroidal hyperpermeability. Both of these indicate whether your focal treatment will succeed or whether you will have a more extensive disease process which you have not covered with your focal treatment. Okay, thank you, Dr. Srilekha. I'd like to invite Dr. Vandana to give her to present the consensus algorithm, which I believe she has done with the immense under the guidance of Dr. Sudarshan also. So, Dr. Vandana.
Good evening, sir. Okay, sharing my screen. Is it visible? I hope everyone can see my screen.
Yeah, your screen is visible. Please continue.
Okay. First of all, thank you, sir. So I'm going to, and a very good evening to one and all. So today I'm going to present an algorithm on the diagnostic approach to a case of bilateral granulomatous panuveitis. So first of all, I'd like to say that a thorough clinical history, clinical examination, both ocular and systemic, along with the classification of uveitis is the most important step in the diagnosis of any case of uveitis. So coming to this particular algorithm, first of all, we have the Manto test. A tuberculin skin test, a positive tuberculin skin test is alone does not help in the diagnosis of ocular tuberculosis. Tests like a positive quantiferon TB gold, the history of tuberculosis or the history of a TB contact, or the history of a patient coming from a TB endemic area are points which help suggest the possibility of a possible ocular tuberculosis. The clinical picture of focal or multifocal choroiditis, serpiginous choroiditis, a choroidal granuloma, or a subretinal abscess, along with the positive clinical investigations for TB helps in diagnosing a case of ocular tuberculosis. On the other hand, an elevated serum angiotensin converting enzyme, the serum ACE levels, it is not very specific. However, in the presence of raised intraocular pressure, the presence of trabecular and iris granulomas, optic disc granuloma, periphlebitis, the characteristic candle wax drippings, or even the presence of multiple peripheral chorioretinitis can help us in diagnosing ocular sarcoidosis. Another clinical scenario where you have bilateral granulomatous panuveitis with disc edema and multiple SRF pockets. Again, we may have two differential diagnoses here. If there is a presence of history of ocular surgery or trauma, it is more suggestive of sympathetic ophthalmitis. If not, it is more in favor of a VKH disease. Now, coming on to the syphilitic test. What if we get a positive VDRL or a TPHA report? Again, raised IOP, multifocal chorioretinitis, and ground glass retinitis with vasculitis is very suggestive of syphilitic uveitis. Once again, syphilis is the great mimicker. It can present in any form, it can present in any pattern, and therefore testing for syphilis, doing both the specific and the non-specific tests becomes very important in any case of uveitis. Let's take another patient where you have an elderly patient presenting with bilateral granulomatous panuveitis, but here with a history of systemic or ocular malignancy. And you see an inadequate or no response to oral steroids. That is suggestive of ocular metastasis. Another very slightly rare but possible case you can see is granulomatous uveitis, panuveitis with beaded corneal nerves, iris pearls, and bilateral interstitial keratitis, very specific and very typical of Hansen's disease. Next, again, you have granulomatous panuveitis, but with severe vitritis, and you have got extensive retinitis. It suggests a viral etiology can be possible acute retinal necrosis. And lastly, last but not the least, we may always or many a times end up with something which is idiopathic. Thank you, sir.
Thank you, Dr. Vandana, for presenting the algorithm in a very lucid way. Could you start the screen share? Yeah, thank you. I'd like to invite comments from both our UVA panel about the algorithm, please.
Can we have the algorithm on?
Yes, sir.
Yeah, it was very good actually. But that's what I. For the granulomatous panuveitis part, a few things that again, like with the case which Nivedita presented, sometimes it even in masquerade and other things, you get an early good response to steroids. So that really takes away the thing. So recurrence, if it's recurring again and again, or if it's persistent with some debris, then you probably think. So inadequate or no response is not always the case many times. It really responds many times. It can still recur. We have instances of patients done a couple of times biopsy and then still finally like coming back with metastatic disease or a lymphoma. So steroid response alone may not be the criteria for masquerade, but yes, like partial response. When you look at it, even methotrexate is actually one of the treatment for it for lymphoma. So that's one thing. But otherwise, most of the things are quite okay. Syphilitic diagnosis by exclusion, you just actually, when you, as you are mentioning, so you don't get it that easily straight away. It's not necessarily granulomatous anteruveitis many times. You get the posterior uveitic part is a bigger mimicker than anterior. So anterior can present with granulomatous or non-granulomatous, not so specific. But the posterior uveitic part mimics any of these. If you want, in immunocompetent, what we have seen in syphilis is the placoid chorioretinitis, which they classically describe, is an immunocompetent. The diffuse retinitis and the vasculitis part is in the immunocompromised. So maybe you can group it like this. Any granulomatous panuveitis with vasculitis or a choroiditis, then probably you're dealing with TB or sarcoid. Granulomatous panniculitis with exudative RD can be VKH or sympathetic ophthalmia. Okay. Granulomatous panniculitis with, like intumescent lens or a thing can be lens-induced uveitis. And the other infective ones can be Hansen's and syphilis.
Dr. Natasha, any parting comments regarding this?
Just in pediatric, when you are looking at an early onset granulomatous uveitis, then again infantile sarcoid and its closely related Blau syndrome, we should keep in mind. They will present very similar to JIA, but very early onset. And we'll have some systemic features of sarcoid also. And in the ocular metastasis, I would add paraneoplastic also. It need not be a direct metastasis into the eye. Most of these uveitic things, uveitic mimickers would just be paraneoplastic, not direct mets.
Yeah, Blau is a very important point. Actually, we generally miss it out of late. I mean, I've been like, it's been a learning experience for me for the past 4-5 years after I published a case. Actually, so it's a very important point that anything granulomatous in a child, it is probably not JAA. So you need to think of something else.
Okay. Thank you, Dr. Mandana. That was nice, and thank you to our panel. We've had a very nice, discussion covering a lot of points, and I hope it's been useful to all our viewers. So that comes to the conclusion of today's session, and I'd just like to thank our IT team and our SciComm over here, who's done a good job coordinating between everybody. And I'd like to thank all our friends who've come online as panelists and speakers, Sudarshan, Darius, and everybody. I think Darius is the only one who's sticking beyond his bedtime and dinner from the retina session. So anyway, nice to see all of you, and we hope we'll meet all of you tomorrow again, where we start at 9 o'clock, isn't it? We'll start at 9 a.m. tomorrow, and we'll have the Sushruta oration, where the incomparable Dr. Jeevanas Titial will be talking to us about cataract surgery customized outcomes. So anyway, we look forward towards tomorrow. Yeah, Dr. Neeru, would you like to conclude?
Thank you, Uni sir, Manoj sir, and all the faculties for the wonderful discussion. That was really informative for us. So that brings us to the end of today's proceedings. And we are starting bright and early tomorrow at 9 a.m. sharp. And we have a variety of interesting discussions in stock for you tomorrow, especially in pediatric ophthalmology, cataract, and glaucoma. And as Uni sir said, we also have the much awaited Sushruta oration by Professor Jeevan Singh Titial sir. And we sincerely expect all your active participation tomorrow as well. So thank you all for your patient listening, and good night and take care.
Thank you. Thank you, everyone. See you, hopefully in person.